system COVID-19 for allowing nodal officers to report daily status and stock, which are being monitored on the daily basis at the state level. See here now how we monitor. State is receiving the following reports through DMAR portal on a daily basis. So this report always generated at 12, and then it is at 8 a.m. it is on the portal. Hospital daily stock information, then the COVID hospital manpower data, the new hospital information, that is a patient's wise, then the hospital training information, COVID-19 government lab data, then the bed occupancy data, oxygen cylinder data, discharge list. So not only cylinder, but even the, you can say this, all oxygen data is also collected. Daily update on the government of the India, that is on the portal of the stock is affected, the affected person is written. Health GOI to take stock of the COVID-19 spread in the Maharashtra, and also stock of various inventories for the government of India. Similarly, the lab data is shared with ICMR online by entering the details on ICMR portal. So that ICMR portal, it is always at 12. So we do it. Daily monitoring of the activities through video conferencing. Here, daily video conferencing between the DMAR and all GMCs, where a daily update and the knowledge sharing is carried out between the medical professionals. So here what we do is focus during the call is laid down these critical cases. Each and every case is monitored, and the experts are sitting in the VC, and then we monitor the patient. They give the investigations, report everything, and the guidelines is given there and there only by the experts. And here the medication prescribed and how the patient responded to the medication provided is also discussed. And if there is some, you can say, addition in that, the experts they advise. So that is, we do near about this we were doing every day, and now it is done twice a week. So complex aspects related to the pandemic, and also share the knowledge on efficacy of the treatment against the pandemic. Here the guidelines are led by the task force, and those guidelines are circulated to each and every GMC, all the physicians and also the pulmonologists and also anesthetists, and they are using the same SOP, that may be in Mumbai or that may be in Gondia. So all over the SOP is same, and the treatment of the patient is same. Gaps in patient treatment and how to overcome, if it are also discussed. If there are some gaps somewhere, then that is also discussed. Also discuss the, if the patient requires shifting, also that is discussed. The interaction is done on the regular basis with the deans, medical superintendents, specialists, lab in charge, administrative staff, and since the inception of COVID-19. So that is on the daily basis. It is not that this is Sunday and that is Saturday. On daily basis, there is interaction on the VC, and each and every, you can say, the facility, also the patient is monitored centrally. The state task force, the Honorable Chief Minister sir has set up a dedicated task force consisting of the various medical professionals to track and manage the spread of COVID pandemic in the state. So the task force monitors and suggests technically to the state and all districts for patient health status, stock of medicine, drugs, consumables, kits, etc. Requirement of the requirements based on the current trends, because every time the trends are changing, and so the requirements are also changing, and so the guidelines are changed, and those guidelines are circulated to each and every person. See, all the guidelines are circulated to the all the can say this councils, and the council circulate to each and every person on their email and also on the WhatsApp. The bed utilization across the hospitals, the spread of the pandemic in the state, and guidelines for that, monitoring of the labs and testing conducted, clinical trials monitoring and updates, preparation and updating of COVID-19 related to the treatment protocol. Also, I am sharing the task force of the Ayush, and under Ayush, I think there are near about 950 immunity centers are started in Maharashtra, and also trying by the this ayushpathy to help the COVID patients. Thank you very much. Thank you very much for the patient hearing. And thank you, MEHS. Thank you, sir.
Thank you so much, sir. That was a very informative and comprehensive as well as up-to-date session on what all activities are being happening and the enormous work that is being done by DMER. We are very thankful to you, sir, for taking out time and briefing all of our viewers on this important topic. Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you.
Excellent talk, Lahane sir.
Thank you. Thank you, sir. Thank you, Super sir.
Yeah.
Our next topic is one of critical importance, which is on the brief overview of vaccines and related issues. And we have with us none other than Dr. Avinash Supe, sir. Once again, sir does not need to be introduced. He is the chairman of the MCGM COVID Task Force. He's the former dean of St. GS Medical College and KEM Hospital, as well as former director of medical education and major hospitals MCGM. So we are very privileged to have you here with us today. And I request you to please share your slides and begin your session.
Sure. Thank you, Devanshi. I think I would like to say that I am not the MCGM COVID Task Force. I look the... Hello?
Yes, sir.
Ek minute. I look the death audit actually
Supe,
of
sir,
the MMRDA.
Supe, sir, you are also task force, you are also death audit chairman, you are also guidance.
Tell me, sir.
So it is not that you are having the only one portfolio, you are having all portfolios.
Sure, sir. Thank you so much, sir. At the outset, let me really thank MUHS, and I'm really congratulate Dr. Lahane for an immense work he has done during this time, and the work done by the government setup and the public hospitals has been immense. And I would like to really appreciate, and everybody should note that how public hospitals have stood to the test of time in these times of pandemic. Now, the topic today is COVID vaccines, and I would like to really go quickly over what are the types and dilemmas which are mystified in this COVID vaccines. Now, I have no financial interest to declare, and I would like to thank Maharashtra University of Health Sciences. Now, let me understand the birth of a first vaccine, viral vaccine. In 1760, smallpox was killing nearly 4 lakh Europeans, and a strange rumor started to spread. Daily workers never seemed to contract smallpox. The rumor reached a surgeon, apprentice named Edward Jenner, who recognized that dairy workers have already been exposed to a similar virus called cowpox, and Jenner started to inoculate children. So what he did, he took a milkmaid infected with the cowpox, and he inoculated James Philip, one small boy in his community, with cowpox pus. And Felix fell ill with a mild case, and he recovered. Then he collected scabs from a smallpox patient and injected into the Philip, and Philip was unaffected. And that's way you find the vaccine was born. And the term vaccine and vaccination are derived from variola vaccina, that is smallpox of the cow, and the term devised by Jenner to denote cowpox. Having said that, I think Lahane sir very rightly said that we are now seeing the second. We have started seeing the second wave all over the world. And though it is not as high all over the world, in India, it is almost reaching to the old and it is crossing sometimes. Now, we have more than 13 crore patients today and 20 lakh deaths. If you look at the pattern in a country like Sweden, they had a double pattern. You know, they saw one wave and another wave in the winter. But in United Kingdom also saw many waves. Look at the nearly due cases. And Brazil has been extremely hot spot today. The number of deaths, the number of deaths have risen so high in Brazil in the second wave. Compared to that, India has seen now a second wave, which is, we have started reaching to the first wave, but though we are somewhere around 80,000 versus 95,000. And these are the number of active cases in India. And these are the number of deaths which have started rising, fortunately less than what it was before. On this background, let us understand the vaccines. What are they and how do they work? What are the technology, dosages, delivery, and cold chain maintenance, pros and cons, efficacy and safety, and vaccination schedules and logistics. Now, the principle behind Jenner's approach was using a weaker version of virus to create immunity to more deadly version. And this is still used in vaccines. But today, there are many other methods of vaccine production, and these are being used to create a new COVID vaccine in a record time. According to the WHO, there are more than 150 COVID vaccines are under development, and 44 are in clinical trials, and 11 are now in a late testing stage, and 5 or 6 are already there in the world. The speed at which the vaccines have developed is phenomenal. The high efficacy of vaccines is a great news, but we really don't know about the long-term safety, the duration of the protection, and distribution of that means future COVID vaccine trials after a particular candidate becomes standard care. Now, let's first understand this coronavirus. It has multiple proteins. It has nucleoprotein, it has genomic RNA, membrane protein, and spikes glycoprotein. The most important is the spike glycoprotein. So coronaviruses are named after these crown-like spikes, and scientists monitor changes in the virus, including changes in the spikes. So this is what is given the name as corona because it means crown. Now the COVID vaccines are mainly types are Covishield, that is done by the Serum Institute. Covaxin is Indian vaccine by biotech. Pfizer Moderna, which is a messenger RNA vaccine, and plasmid DNA vaccine, that is Zydus Cadila. But we'll go a little deeper into this. Now, the first is live attenuated vaccine. What do you mean by that? You take a vaccine, a virus, and you attenuated it or weaken it by its activity by either putting it into some kind of chemical or heat kind of a treatment. Very effective, can provide a lifetime protection in a single shot. Doctors may not advise them for people who are especially with weak immunity. Now, the previous examples of vaccines which are live attenuated are measles, mumps, and rubella, chickenpox, which all of us are aware of this. The companies are developing are Coadministration and Indian Immunological, but we still don't have this live attenuated vaccine today. The second is an inactivated vaccine. What do you mean by it? Inactivated vaccine is virus has been killed. It has been killed during with the heat and chemicals or radiation. It's a very safe, even with people with unhealthy immune systems, and often require a booster shot because immunity they provide is not long lasting. Inactivated vaccines already in use are polio, rabies, and hepatitis A. And these are Sinovac and Sinopharma are the Chinese vaccines, and Bharat Biotech is one which is the Indian vaccine, which we call Covaxin. So when we talk about Covaxin, it is the virus particles are inactivated, higher dose needed for immune response, past successes with rabies and polio, and efficacy data was awaited, but now I think that final trials have come and we have 81% efficacy, and therefore this is now being active and people have been using it. The third type of vaccine is messenger RNA vaccine and DNA vaccines. What do we mean by that? An adenovirus is entered by the cell and it is broken down into messenger RNA, DNA and messenger RNA. So viruses have their own genetic codes. So DNA and RNA vaccines do not contain whole virus. Instead, scientists insert a part of the virus's genetic code, which delivers instruction to the human body about how to recognize and attack virus. So it is safe, fast, and easy to design. The problem is these vaccines need to be stored at a very cold temperature, and therefore the distribution becomes difficult. You know, sometimes -40, -60. And that is the reason why India did not really go for these vaccines. And these are Moderna vaccine, Pfizer vaccines, and Zydus Cadila vaccine. Though there are some trials going in India, currently this is not being in use in India. So messenger RNA vaccine, Pfizer, Moderna, no actual pathogen, genetic code, antibodies and T cells. Challenge is to maintain the cold chain worldwide distribution. Similarly, plasma DNA vaccines were conducted, and the results are little awaited. And they were also, basis was on the West Nile virus and generated complementary DNA fragments and improved stability, easy large-scale production, but no infections agents. The next kind of a vaccine was subunit vaccine. That means part of this is injected, what we call the vector basis. That means subunit vaccines do not contain again the whole virus, but contain some part of it, and something like, and it includes the recombinant polysaccharide conjugate. And these are the vaccines which were Novavax vaccines, which we normally call hepatitis B, HPV, all these are vaccines of that type. And the last one is a vector vaccine, where viral vector vaccines like Trojan horse, especially part of the deadly virus's genetic code is hidden inside a harmless virus. And then it is injected. Now, this is what was done for Covishield. So what they really did was that they used the chimpanzee virus and used the viral vectors of the adenovirus of this corona, and they injected and created a vaccine. So it may not work for people who are already immune to harmless live virus, but it is fairly good response, and the trials have shown that this is good. And this was the Oxford AstraZeneca vaccine. So cells of chimpanzee modified to form vector, genetic code of COVID-19 spike protein isolated and added to the vector, strong immune response to one dose, but however, as a safety, we give 2 doses, safer in children, elderly and comorbid, but it is being now restricted to elderly and comorbid today in India. Completed trials somewhere in September in UK and Brazil, and India started in 16 January. So Oxford Zeneca vaccine for COVID-19 is more rugged than messenger RNA vaccine. And DNA is not fragile as an RNA, and adenovirus's tough protein coat helps to protect genetic material. So because of all this, I think India selected to have Oxford vaccine and Covaxin. And I'm sure over years, the new vaccines will also start to come. The major problem of the other vaccines were the refrigeration, 2 to 8 degrees, how much it's easy for us to really give it and distribute it. The other vaccines were Sputnik 5, started in Russia, in Argentina and all, they are giving all this. Indian collaboration with Dr. Reddy's lab, same type of Covishield, adenovirus vector vaccine. In China, as you say, they are using Sinopharm and Sinovac, which is inactivated like Covaxin. Now, Government of India issued directives. I think initially they said authorized age is above 18 years. Co-administration of vaccine. That means other vaccines should be separated by interval of 14 days, especially those who are taking yellow fever or rabies vaccine. You should have a gap of 14 days. Then interchangeability of vaccine is not permitted today. If somebody has taken Covaxin, you should take Covaxin. Then a person with a history of anaphylactic reaction to sulfa or penicillin should be careful and take it only after doctors kind of under advice. And pregnancy and lactation, we have still not opened this vaccination. Now, I'm sure person with active symptoms of COVID, person who has given anti-SARS-CoV monoclonal antibodies or plasma should avoid taking it for 4 to 8 weeks. And acutely unwell and hospitalized patients should not be given this vaccine. Vaccine should be administered with caution in persons with history of any bleeding or coagulation. Now, one more thing I would like to say, that those who are taking heparin or warfarin should stop these medicines for 2 days before taking. Rest of all people, like who are taking the thinners like aspirin, or those who are taking the especially rosuvastatin or something like that, they should continue to do this and take vaccine anytime. They need not really stop this. Then I'm sure patients with infection who had previously had past history, or those who have chronic morbidity, they should continue to take vaccines. Age is no bar, and vaccine-specific contraindications may apply only to new information comes. So whenever there's a new information coming, people are using it. But as such, people have now, we have more than, as I said, 6 crore patients have taken, and it has found to be very safe. The difference between Covishield and Covaxin, the doses are same. Both require 2 doses. Initially, they had said 4 weeks apart. Now the government has said take about 8 to 12 weeks apart. And storage conditions are also same. And it is given intramuscularly. And it is fairly accepted by people now. Now, some mild AEFI reactions were found. Most of the people get a tenderness at the site of injection, then headache, fatigue, myalgia on the next day. When you take second dose, sometimes the fever and malaise are more than the first dose. Paracetamol is more than enough. Very rarely people have reported as demyelinating disorder. Initially it was given. But we do not have any kind of such report in India, and therefore it is fairly safe, and people should take this vaccine without any worry. Now, the next question is, why are we needing 2 doses? Why we need 2 doses? Now, it's very classically, there's something called as the primary immune response and immune memory. So when somebody takes a first injection or infection, you get some degree of a primary response, but over a period of time, that immunity starts coming down. So when you take a second dose, then you start getting the secondary immune response, and then you have a longer immune memory. Maybe it is for 6 months to 1 year, and that is what people are saying. So therefore, we need a 2 doses currently, but there are some vaccines like Pfizer, many of them, or Johnson & Johnson vaccine, which is only 1 dose vaccine. But in India, we are following the 2 dose vaccines. The first shot helps you to body recognize the virus, and while second shot strengthens the immune response, this makes your body more prepared to fight infections. And therefore, people have been now recommending Covishield 8 to 12 weeks now. So vaccination schedule started at 16 January. In February, we started giving frontline workers. March, we are giving 60 plus and 45 with morbidity. And from April 1st, we are giving 45 plus. It is amazing to see that Maharashtra is the leader now. Maharashtra has done more than 65 lakh doses. We are going at a 3 to 5 lakhs per day, which is an amazing speed. We are number 1 in the country in vaccination. And Mumbai has done also more than 12.5 lakhs with more than 50,000 doses. And there are now hundreds of centers across the state and country which are doing this. Now, one important question was, speed thrills, but will it kill? Now, Pfizer vaccine worries Norway as 29 elderly patients die after taking shot and 23 die in Norway. But then they analyzed all this and they found they were patients from 75 to 80 years and they had fatalities because of their own diseases. Now, if you really look, then another question was about thrombogenicity. Now, if you see, the whole principle was endothelium causes imbalance of ACE2, host cell death, and it causes more amount of coagulation and more amount of kind of a thrombosis, myocardial infarctions and paralysis. This was noted in some countries, but if you really see, it was seen in something like Norway, but in India, no clotting cases in India, Oxford dose. This was officially declared. Now, if you see the deep vein thrombosis after surgery, it is 4 to 5% in the Western world, but in India, it is well documented. It is less than 0.5%. So as such, we have less thrombogenicity. So in India, we have not seen this, but we have to be all careful about this. Now, the safety of the vaccines, preclinical trials where the vaccine is tested for toxicity and efficacy of animals. The trials involved humans, follow a strict 3-phase processes. So it is fairly safe. Most of these vaccines have gone through this safety profile. And gene technology like DNA and RNA stands was being used for the first time. So that was a concern. But therefore, permission to roll out was given after checking safety data. And it was called as an emergency permission. It was for both Covishield and Covaxin. But now over the last 3 months, we have got a fairly good safety data. And we should continue and would not bother about the safety. There are adverse effects, as I said. Chance of getting severe adverse effects are very low, 0.5%. And mainly are injection to reaction, which is maximum. Fatigue, headache, fever, chills, and the fever is in about 6 patients. And 6 people have died during the trial, that's what they said. But the deaths were not related to the vaccine. And the same thing they have found when they analyze the deaths which have happened after the vaccination. 1 or 2 people have got swollen lymph nodes, but we need to really watch this. Now, there are 2 words we should remember. Immunogenicity and reactogenicity. Immunogenicity is the ability to induce humoral or cell-mediated immunity. We are normally all looking at the neutralizing antibodies, but we are not able to really look at the cell-mediated immune response, while reactogenicity is the property of a vaccine being able to produce excessive immunological response and associated signs and symptoms. So many of these vaccines have some amount of reactions, but they have a fairly good amount of immunogenicity, which is up to 71 to 81%. That means 20% of people may not get adequate immunity and they are liable to get some degree of an corona again. However, that would be milder because of a good cellular immunity. And so when you know about the vaccine shot safety, NEJM also had said that criticality have emphasized that these allergic reactions are uncommon, like anaphylaxis, and they are in 1 lakh doses. And most of them recover very fast. Now, vaccine for pregnant and breastfeeding mothers, we have limited data about this. Currently, it is not recommended for pregnant women and breastfeeding women. Now, people are looking at this data, and maybe in next few months, it will be available to the pregnant women. Now, coming to the efficacy of the vaccine, an ideal vaccine should prevent three things. One, it should prevent the disease itself. Secondly, it should prevent the infection. That means it would create a milder form of the disease. The spread of the infection is controlled. And the third is transmission, which means if you got infected, you should less virus than you have been vaccinated. While we do not know about these vaccines can help the prevent illness, we only know today that probably it reduces the severity of the disease. We also don't know about how long this immunity lasts. Most of the vaccines have efficacy of 70%. You have 95%, Covaxin has 81%. That means majority of the people will be prevented from getting a severe disease. What is important is that if you have a non-immunized people, then chances of everybody getting infected is very common. But if you have a little herd immunity, then less people will be infected. And this is very well seen today in health workers. When first time in April, we had lot of people coming positive. When one person was positive. Today, we are getting health workers positive. But because most of the people, health workers, are immunized, we are not getting numbers and numbers getting positive. And that is a good sign that vaccination is working to some extent. Long-term effects, it is too early to know if COVID vaccines will provide a long-term effect. We really don't have that data, neither have experience. How strong this protection is, we don't know. And most COVID-19 vaccines being tested or reviewed are not being used in 2-dose regimens. So I would advise everybody should take vaccines, 2 doses at interval of 8 weeks. Those who have taken 24 weeks may have to do antibodies at the end of 6 months and see whether we need to repeat a dose. The current status, more than 6.87 crores vaccinated in India, mainly Covishield, but few Covaxins. Few hundreds have adverse effects which are mild. Deaths are unrelated. And it's the largest vaccination program in India. Now, which vaccine type is the best? Now, every type of vaccine has its own pros and cons. There has been a lot of debate which is going on. While some vaccines provide stronger or longer based immunity, longer lasting, they may be more difficult to produce and store and transport. I think people should be okay taking Covishield. If they have some allergic reactions or their immunity system is weak, they should prefer a Covaxin because Covaxin has less side effects and less reactions to these people. So we'll have to really wait, and it's difficult answer at this stage. To summarize, India is rolling out the largest COVID-19 vaccination drive today. We have initial safety and effectivity data, and it is quite satisfactory. We have rolled out more than 6.87 crore people. That's a huge number, and it is, I think it's one of the now top program in the world, and it is working well. People are really doing it. I feel the more people are coming from the middle class and a higher class, there is less amount of motivation from the lower class, which we need to really improve by training people and making it public awareness. It is voluntary, but all healthcare workers with no contraindication should take vaccine under guidance. I feel in next 1 or 2 months, we should open it to everyone, and we should try to see that we create some kind of an herd immunity. So we'll be able to control this corona pandemic in next few months, I think. And long-term effectivity data is awaited. We really don't know about it, and we'll continue to await the trials and reports from them. So thank you very much, and wish you all and safe life in future.
Thank you so much, sir. I think it was a very exhaustive overview and has covered various topics of debate in a very beautiful manner. I really thank you a lot, sir. And I think our more than 450 viewers who are streaming this live on YouTube right now have really learned a lot from this session. Thanks again, sir.
Sure.
We'll move on to our next session. The topic for which is diagnostic updates on COVID-19 pandemic. Coming straight from the horse's mouth, we have our very own Dr. Geeta Natarajan Madam, who is professor and head of the Department of Microbiology at GS Medical College and KEM Hospital, Mumbai. Ma'am, I request you to please update all our viewers on the newer diagnostic techniques in COVID-19 pandemic. Ma'am, if you could please go ahead and share your slides.
Is it visible now?
Yes, yes, it is visible.
Good morning, everyone. And at the outset, let me thank Dr. Devkar and the team at MUHS for giving me this opportunity to speak on the diagnosis of SARS-CoV-2, which causes COVID-19. The title initially was an update on microbiological diagnosis, and you also recently referred to it while giving the introduction, but there is nothing that has changed over the last 1 year in terms of diagnostics. And therefore, I would like to restrict this talk only to the microbiological diagnosis that is conventionally happening for this particular disease. So the concept of testing was well understood, and therefore it was this, that Dr. Tedros, way back in March 2020, when this became a global pandemic and a disease of emergency proportions, the three words that were always used was test, test, and test. And subsequently, it got replaced by test, track, and treat. So the importance of testing is something that is necessary for this particular virus, for the disease that it causes, because it spreads very rapidly. And we are seeing the effects of a rapid viral spread in terms of the second wave in the state of Maharashtra. Before I go on to the diagnostics and their uses in SARS-CoV-2, just a brief overview on those characteristics of the virus which are driving the diagnostics and which make us interpret the results the way we do. This has been mentioned earlier also, that COVID-19 is caused by a distinct and novel coronavirus, and therefore it was given the name SARS-CoV-2. It is genetically unrelated to any of the other 6 coronaviruses that are known. It is characterized by both structural and non-structural proteins, and as is depicted in this figure, the structural proteins of importance that we use in diagnosis include the spike protein, the envelope protein, and the nucleocapsid protein. There are these non-structural proteins which have not been labeled here, and these include the open reading frames. And they also include the RNA-dependent RNA polymerase, which is called as RDRP. So these are the kind of proteins, both structural and non-structural, which form a part of the diagnostic setting. The most unfortunate thing about this disease is that the clinical presentation could be none. Patients are asymptomatic. The clinical presentations could still be none. The patients will be pre-symptomatic. The clinical presentation could be mild to severe, including sepsis. And all of them have the capacity to transmit the infection to the others. Infection is because of person-to-person contact, majority. It's very few cases that you will have because of fomites and other things, but primarily the transmission is by personal contact. And unfortunately, you have asymptomatic cases and pre-symptomatic cases which can still transmit the infection and will never get detected unless they are tested. Now let's look at the samples in which this virus has been reported. They have been reported in large numbers, in large quantities in the respiratory tract specimens, whether it is upper or lower. Recently, we know that this particular virus can also be detected in oral fluids, and there are tests and assays that are commercially available to test yourself for this. The virus has been detected in stool, but there are conflicting reports of its continued persistence in stool. You have as many reports of its presence in urine as there are of its absence in urine. In a few cases, there are rare reports of it being present in ocular fluids when patients present with conjunctivitis. A small proportion may be present in blood. And in patients who develop central nervous system infections because of this particular virus, it may be present in brain tissue or CSF. But what definitely is known is that it is most frequently detected in the respiratory material, and that's the reason why respiratory samples remain the samples of choice for detecting the presence of this particular virus, SARS-CoV-2. You want to detect, collect an appropriate respiratory sample. The other information that I would like to share is the kind of estimated variation over time of the various markers that you have associated with this particular disease and the specimens of choice. Now, when you look at this figure, we have this blue kind of an amplification curve, which stands for a nasopharyngeal specimen. So we have this period between, which is called as before symptom onset. There is a period which is called as after symptom onset. So symptom onset is some kind of a demarcation to understand which type of test we need to use. Patients start shedding the virus in the respiratory tract much before symptom onset, usually 1 to 5 days before symptom onset. And that is why you get these positivities in asymptomatic and pre-symptomatic cases. The sample of choice obviously will be a nasopharyngeal swab where it is detected in large numbers, or it could be a lower respiratory tract specimen such as the bronchoalveolar lavage. Subsequently, the virus can also be detected by culture, but as is seen in this particular image or representative diagram, you can see that the culture becomes negative almost at the end of 1 week. And that's one of the reasons which has driven this isolation policy from that of testing negative to that of clinical recovery. So many a times we say that it is not necessary to retest the individual after 10 days because that is the only time when the virus is remaining viable in that particular infected patient and the patient remains infectious for others. So by the end of 10 days, most patients who have a mild disease are considered to be recovered, whereas you could have some proportion of patients with severe disease who can still continue the spread the virus for a longer period of time. Coming to the antibody, you also have this virus being detected in stool, but that is probably much better detected when it is about at the end of the first week or second week and continues to be shed in stool for a longer period. But like I said earlier, this is something that is controversial and not many studies support this, but they are present in stool. Let's just consider that. We do not have tests or commercial assays to detect their presence in stool. The classical thing about, or the most distinct feature about the immunological response in case of SARS-CoV-2 infection. Most times for most infectious diseases, we know that the IgM starts earlier, remains for 15 days to 3 months, and then the IgG comes after a week of IgM. And there is a gap of usually 5 to 6 days between the IgM response and the IgG response. In case of SARS-CoV-2 infection, we find that the IgG comes as early as IgM and probably much better response of an IgG than IgM. And if at all, therefore, you want to perform an antibody-based test either for detection, which is not usually recommended, or for understanding the presence of a history of exposure, then it's better to choose a test that detects IgG and not IgM. Having said this, what are the testing modalities that are today available for detecting SARS-CoV-2 which causes COVID-19? The first and foremost is nucleic acid amplification test, which is the methodology used is a reverse transcriptase. You need to reverse transcriptase it because this is an RNA virus which needs to get converted to complementary DNA, which then gets amplified and then gets detected. So nucleic acid amplification test is primarily done using polymerase chain reaction, but there could be other techniques that could be used for detecting the presence of this particular nucleic acid. And it is still considered as the gold standard. Nothing has come as yet to replace this particular modality of testing. The other testing modality that we use is the antigen detection, which is by far the largest that can be rolled out, by far the easiest to do, and by far the most rapid. Most of the antigen detection tests utilize or detect the presence of the N antigen because this is present in very copious amounts. But there are kits which can detect the spike protein based antigens and there are kits which detect both. But primarily in India, we have got tests which detect the nucleocapsid protein, that is the antigen. The third is the antibody response. How to use the antibodies in COVID-19 is something that we will see later. So coming back to the nucleic acid amplification test, one basic fundamental rule that all laboratories follow is to use tests that detect at least 2 virus-specific genes. And it is this that probably helped us to continue to detect patients who were infected with SARS-CoV-2 in spite of having certain cases of UK variants which do not have the spike protein or do not detect the spike protein because of the mutations that happened in the spike protein. They became false negative. So it's always good to have a test that detects at least 2 virus-specific genes. Usually you go for a combination of E, which is the envelope, and N2. These are considered as screening genes, and then you can have specific genes which are called as ORF1AB and RDRP. If you are a clinician, you must have seen these results, and treating patients, you must have seen these results. These are the 4 types of results that you get. The first says that SARS-CoV-2 is detected. That means it's positive and patient is infected with SARS-CoV-2. The second says SARS-CoV-2 not detected. So obviously SARS-CoV-2 was not detected in that particular sample that was collected from the patient. It doesn't mean that the patient does not have SARS-CoV-2. The third type of result that you will get from the lab is inconclusive. What does it mean? So we just saw that more than one particular gene is recommended to be detected by a particular assay that we choose. So if there are two genes, one gene is detected and the other doesn't get detected, and then it becomes inconclusive. So in these situations, the laboratory will usually advise you to repeat a fresh specimen. And the final result that you get probably is an invalid test result. And invalid test results indicate that the specimen that was collected was not a specimen at all. The specimen is inappropriate, its quality is poor, and this also means that we need to repeat a fresh specimen. For most reverse transcriptase PCR test modalities, the turnaround time will vary depending upon whether it's a point of care test such as the CBNAT, or it's a conventional RT-PCR test, a real-time based. So that will vary from 2 to 8 hours. So that's the reason why most laboratories release the results either the same day after 12 hours or maybe the next day. What should be the frequency of testing? If you have a single RT-PCR, CBNAT, TrueNAT, or even a RAT positive test, it should be considered confirmatory. That's it. No retesting is recommended prior to discharge, and this is the policy that even India has moved into, where they say that you don't have to test patients at discharge. Even if you want to transfer the patient from a COVID facility to a non-COVID facility, from a COVID setting in the same hospital to a non-COVID setting in the same hospital. Repeat RT-PCR is recommended in those patients who have tested negative by the rapid antigen test but are symptomatic. Repeat RT-PCR is recommended if patients develop fresh symptoms following a negative test or clinical recovery. So you had a patient, he did test positive, he was infected, he was symptomatic, he became asymptomatic, you decided to discharge, this patient develops another set of symptoms, you do a repeat RT-PCR. Repeat RT-PCR you will always do when the suspicion is high and the first test that you did on this patient is negative. So just giving an example to take us through these modalities of testing, we have a 35-year-old male who comes with fever and dry cough of 2 days duration in the month of March 2021. This is when the second wave is happening in Maharashtra. His throat swab is collected for COVID-19 RT-PCR and the test report says this SARS-CoV-2 is not detected. There are certain options that are given in the right block or column or whatever it is box. So the first option is the result is true negative since PCR based tests have very high sensitivity. The second option is throat swab is not the specimen of choice. The third option is the specimen quality is unsatisfactory. And the fourth option is a repeat test is indicated. So let's go through these options and try and understand as much as we can about the dynamics of this disease and its diagnosis. So the first option is that the PCR result has high sensitivity and therefore this is true negative. Yes, theoretically, PCR-based tests have very high sensitivity because they can amplify the target nucleic acid millions of times through the 40-50 cycles that they undergo. But however, what is the reality about these tests? COVID-19 RT-PCR assays have limits of detection which range from 10 to 1,000 copies. Very few tests which can detect 10 copies per ml. Most of the tests require 1,000 copies per ml to be detected. Detection is also dependent on the genes that have been targeted. So when we saw the structural proteins, we saw that there was an E, there was an N, there was a S, and we had the non-structural proteins. So in a given virus, the number of copies of E are more than the number of copies of the nucleic acid protein, which is more than the open reading frame, or the RNA-dependent RNA polymer, which in turn is more than a spike protein. So if you have a test that is looking for only the spike protein, you could have more false negatives. And that's why most of the commercial assays that we have at least the E or the N2 as the initial or one of the genes, and the ORF or RDRP as one of the other genes to be detected. The detection is also dependent on the quality of the specimen, and there is nothing that is more important than this as a clinician, as a practicing clinician, for us to understand that it is the quality of the specimen that will finally get translated into whether the test result is positive in the infected or no. And of course, it's also dependent on certain laboratory methods that we use, which is called as the strength of the extraction of viral nucleic acids. So if you look at literature and even otherwise, we know that the RT-PCR sensitivity is never ever 100% and does not have a negative predictive value of 100%. So a person could still be infected even if the test is negative. You do it once, it's negative. You do it twice, it's negative. You do it thrice, it's negative, but the person could still be infected. That's the basic premise of a PCR test. For that matter, any PCR test. The second option that was there in the box was throat swab is not the right specimen. So let's look at what should be the specimen. We saw earlier that though the virus can be detected in multiple specimens in the body, respiratory specimens are the types of specimens of choice. It is important to collect the upper respiratory tract specimen if you looked at the variation of the different markers over time. So we saw that the nasopharyngeal swab, the throat swab, etc. So upper respiratory tract specimen collection is indicated in the first week and lower respiratory tract specimens are indicated in the second week. If you have a patient who comes to you with pneumonia, it's okay to collect an upper respiratory specimen, but also do not forget to collect a lower respiratory specimen in these cases. So a person with pneumonia, you can collect a sputum specimen also. The yield has been shown to be better if it is a combined specimen of both a nasopharyngeal and oropharyngeal swab, or at least a nasopharyngeal swab. If not, one can also collect a nasal swab or what is called as a mid-turbinate swab. We do not have experience in collecting the mid-turbinate swabs. And the last one to collect or the least preferred should be the throat swab. That's what the literature tells us. What has been our experience at KEM? We have tested about 32,900 samples between January and March. Not a big number, but definitely a good number. And we are looking at those patients who are symptomatic. I'm not here talking about the asymptomatic. But the numbers regarding which are in the parentheses in relation to the specimens indicate from the total specimens, not necessarily only from the SARI and ILI. And what it indicates is the nasopharyngeal swab is a better specimen, which is better positivity than a nasal swab, than a throat swab, than a nasopharyngeal and oropharyngeal combined, which is like something that is not understandable. But that's what corona does. It creates a situation wherein everything cannot be completed with a full stop. So at the end of this, I would just like to say that throat swab is a good specimen to collect, though not the best. The best specimen to collect would be a nasopharyngeal swab. But what's most important to remember is you collect any specimen from the upper respiratory tract in the initial stages or the lower respiratory tract, collect it appropriately so that there is enough material in that specimen. The third option that we had there was the specimen quality is unsatisfactory. So to understand whether the specimen that is submitted to the lab for an RT-PCR assay for COVID-19, we use assays which contain what are called as internal controls, which are nothing but human genes. Human genes will only be present if the sample is of human nature. And therefore, if that particular gene is detected in a good amount, then we say that the specimen quality is good. And when this gene is not detected, that's when you get the invalid test result. So poor specimen quality cannot be ruled out if in almost all cases. Option 4 was a repeat test is indicated. Of course, a repeat test is indicated since the patient was symptomatic and came to us during the second wave, and during a pandemic, you consider every person who is presenting with an influenza-like illness to be potentially COVID infected. So it has been reported in literature that testing a second time in a clinically suspected symptomatic case or even an asymptomatic high-risk contact or contact of lab-confirmed case improves the sensitivity by almost 17%, and that's a good jump. So taking this into consideration, most laboratories will ask for repeat specimens after 24 hours. So if we look at the options were that the result is true negative, maybe it is true negative, but we cannot rule out the possibility of a false negative, and that's how we have a tick and a cross. I would still suggest that throat swab is probably not the specimen of choice, as whenever possible, try and collect a nasopharyngeal swab and a throat swab, and both these samples should be put in the same VTM tube. Many a times we get 2 swabs collected from the patient, which is very good. But these are added to 2 different tubes. And that probably will not improve the yield as much as if we put both the swabs in the same viral transport medium. The specimen quality is unsatisfactory. That is a possibility that exists, or that could not be a possibility also. And yes, a repeat test is indicated. So there are two corrects in these options. One is that throat swab is not the specimen of choice. Collect a nasopharyngeal and a throat swab, or a nasal and a throat swab at least. And a repeat test is always indicated when the clinical suspicion is high. So do not hesitate to collect a repeat specimen. This is a second scenario where you have a 45-year-old diabetic male who presents with fever, cough, and breathlessness and is detected to be infected with SARS-CoV-2. And this is when the clinician requests for CT value. I think I've had telephonic discussions with a lot of clinicians who were left unsatisfied at the end of the discussion that I will not give CT values. So why was this kind of a decision being taken? We need to understand 4 or 5 things. One is that the CT value does not actually indicate viral load. The CT value has no correlation with disease severity. We see patients who are actually asymptomatic contacts or just come for screening because they want to undergo some surgery or procedure, and they have a CT value which indicates that there's a lot of virus that is likely to be present. CT cutoffs again are different for different assays. So you do a test with one assay, you do the same sample and run it with another assay, you're going to have 2 different CT values. So what are we going to do with that? So what determines the CT value is the quality and the type of specimens collected. So if you collect the right specimen, and if it is of a good quality, and if the person is actually infected, you will have a good CT value indicated the virus is present in large numbers. In short, it will just tell us that the virus is present. It doesn't matter to what extent it is present. It just doesn't matter at all. And there is also suggestion that one should not rely on CT value for further management of patients or prognosis. And I hope this is something that is followed by the clinicians, whether they agree with me or not. So this is just a pictorial of the actual amplification that happens when a sample is run through an RT-PCR. So we see some amplification has happened in one particular sample at around 20 to 22, and another sample that probably has amplified at 32. So does it mean that this particular sample, this particular person is less infectious, will suffer from less severe disease? No, not at all. This probably indicates that yes, maybe there is actually a lesser number of viruses there, but it also indicates that the specimen quality could have been poor. So CT or cycle threshold is the cycle at which an amplification is seen. If you have a CT that is lower, you always have a cutoff for any PCR. Most of the commercial assays have a cutoff of around 40. Some have at 45. Some don't have a cutoff at all. Some have at 36. So if you have something that amplifies at 20, it's obviously having more viral nucleic targets than something that amplifies at 32. So all commercial assays that we are using currently, which are ICMR approved, US FDA, emergency use approval, they are all qualitative tests. You must have heard RT-PCR test results of HIV, HBV, where they give you an actual number that this is the number of viral copies that is present in the specimen. What is the specimen there? It is blood. And what is the specimen we are talking about here? It's an upper respiratory specimen. It's a swab. How well can you collect a sample on a swab? How uniformly distributed is the virus going to be in that particular swab? And when you put it in VTM, what happens to all the material that you collect? Does it really get dispersed equivalently in that swab, in that viral transport medium? How much of the viral transport medium are you removing? So all these are parameters which obviously will tell you that a lot of factors go into what finally comes as a cycle threshold. So the cycle threshold is actually dependent on the gene target. So if you're looking for E, then it will have a cycle threshold which is going to be earlier than an S. It is going to be dependent on the extraction platform, how well the nucleic acid has been extracted. It will depend on the amplification chemistry, what kind of cyber green or TACMAN or what kind of chemistry are we using. It will finally depend on the quality of the specimen. So don't look at the CT value. Don't ask for the CT value. If you have your questions, you can have a one-on-one discussion with the lab asking that, I would just like to know what is it. But otherwise, CT value does not represent anything at all. It does not have a correlation with disease severity. And this is a study that has been published from Mumbai. And that's the reason why I chose to share it. There are multiple studies that are available, pros and cons of CT values and viral load. And CT cutoffs are different for different assays. So yes, CT value does not indicate viral load. The kits that we are using are qualitative assays, and therefore it will only tell us something about the relative concentration of the viral nucleic acid in that particular sample at that particular point in time using that particular assay. CT value has no correlation with disease severity. And the most important thing that I want all of us to keep at the end of this session would be that the quality and the type of specimens collected determines the CT value and determines various other things. It determines the test accuracy, determines test positivity, and therefore concentrate on collecting an appropriate specimen and collect it well. So many a times I have seen people collecting a throat swab, they just tell mukh hol diya. Then you take a swab, insert it, touch the throat and take it out. That's not how a throat swab needs to be collected. The same is true with the nasal and the nasopharyngeal swab. We think we are collecting the nasopharyngeal swab, but we always land up collecting the nasal swab. A nasopharyngeal swab collecting is absolutely painful. Okay, the person has to wince. Sometimes there is tears trickling from the corner of the eyes. That's how you collect a specimen, and not just like that. So the nucleic acid detection methods, the likelihood is dependent on various factors, and the qualitative molecular assays should be used. This is something that I always believe in, and I don't think many of the microbiologists want to agree with this. But a qualitative molecular assay should be used only at diagnosis and not for other decisions, and not for finding out if the patient has been cured. A patient is cured based on the clinical recovery of the patient. A patient is not cured because the nucleic acid that was present is now absent. This is not like the TB kind of a thing where you have smear positive and smear negative at the end of 6 months and we say that the patient is cured of TB. No, absolutely not. The third situation is that to do with rat, a 26-year-old asymptomatic woman but who is a contact of a lab confirmed case is detected positive by a rapid antigen test. The clinician asks for a confirmatory RT-PCR test and the lab says it is not required, rat is a confirmatory test. The patient is advised strict home isolation and provided medications. So the rapid antigen tests are highly specific and therefore do not need to be confirmed by an RT-PCR test. And that we see day in and day out. When by mistake we put the RT-PCR test, we find that it comes positive. Then we, when we make the entry in the ICMR portal, we come to also understand that this is rat positive. Rats are positive only when viral load is high. So obviously this person is more infectious than a person who is RT-PCR positive in most instances. So if you want to decide on isolation precautions, it is best to do a rat in a symptomatic patient. So if the person is symptomatic, that person needs to be isolated, whether at home or in the hospital, depending upon the clinical spectrum in this particular patient. But if you want to detect cases in those who are asymptomatic or even in those who are symptomatic and you're not interested in knowing the infectiousness of this patient, then you please only do an RT-PCR. Home isolation is appropriate for a young symptomatic person, and RT-PCR would be recommended only when we have an asymptomatic person in whom a rapid antigen test gave a result as negative. So in a symptomatic person, if rat is negative, it is mandatory to do an RT-PCR. So this is about a rapid antigen test. Just concentrate on the last statement here that most of the tests have sensitivity over 80% and specificity over 97%. And that's the reason why it is said that it is not required to be confirmed. So there are a lot of advantages of rat, which if you have done, you know that the results can come back to you within 30 minutes. So you are many a times asked to wait and then the report is issued to you at the table at the lab itself. The limitations of rat obviously are that it is less sensitive than PCR. It is less sensitive than viral culture. It does not rule out infection if the test result is negative. And a negative antigen test, again and again, there are certain statements which I would be repeating, and that is because there are certain points that need to be emphasized. And the test lacks control for confirmation of appropriate sampling. You had that kind of a control in the RT-PCR, but you do not have sampling control in rat test. And this is the diagnostic algorithm of ICMR for rat. Then the last case scenario is a 45-year-old male healthcare worker who tests positive for COVID-19 by RT-PCR in June 2020, or who tested, we should say. His rapid IgG antibody test, which was done in September, turned out to be negative. So could it be that the RT-PCR result is false positive? Could it be that the IgG antibody has waned to undetectable levels? Is it that the format used for detecting antibody has low sensitivity? And is an IgM antibody test a better test to have been done on this patient? So let's look at these points regarding an antibody. So when you have a patient who is being detected RT-PCR positive for COVID-19, you expect this patient to develop antibodies. Unless the patient is in such an immunosuppressive state that he cannot develop any antibodies. But otherwise, healthy people should develop antibodies. So is it possible that this RT-PCR result could be false positive? Yes, there is this possibility always. The second option there is the IgG antibody has waned to undetectable levels, and yes, the immune response to this particular disease is something that is being learned, it is evolving, and everything about it is not known. But what is definitely known that it doesn't wane off in 2 months or 3 months. So it is unlikely that it has waned to undetectable levels. Is the format used then for detecting antibody having a low sensitivity? Yes, a rapid test which will definitely have a lower sensitivity compared to an ELISA, and there is a better option today which goes by the name of CLIA, CLIA. So CLIA has the highest sensitivity, then you have the ELISA, and then you have the rapid. So maybe this lab could have used an ELISA or a rapid or a CLIA to look at the antibody. The last option here is an IgM antibody test would have been more appropriate. As far as COVID-19 is concerned, trying to detect the presence of IgM antibodies, A, is inappropriate at any time, and B, it is inappropriate after 2 months. So if at all we want to look at an antibody in a COVID-19 infected patient, look at IgG antibody in almost all cases. So what is the potential utility of serology? Because we are still exploring the many unknowns in serology, there probably are certain situations wherein serology could be of use. We saw all these surveillance studies that have been published from time to time from India, from different states, different cities, and even from pockets of different cities. So it detects the exposure to the virus, and it detects the extent of that exposure to a particular virus. It has a potential in the aid of COVID-19 in RT-PCR negative patients presenting later during disease course, wherein you need to do both IgG and IgM. It detects disease prevalence in the community. And we know that all those who have been involved in this plasma trials, it was used to identify potential convalescent plasma donors, but the test was not this kind of a format. It was a quantitative assay that they had suggested. And to evaluate the immune response to candidate vaccines, like Dr. Supriya suggested, maybe there will be a time when all those who got vaccinated will want to know what is their antibody response. And after a period of time when we expect the antibodies to wane off, we want to know whether the antibodies are still there or whether a booster shot is required. So all that is still evolving. Drawbacks definitely are known, and that is that if you take it early in the course of the disease, it's going to give you a false negative result. And we do not know for how long these antibodies remain, what is the shelf life of this antibody in vivo, and therefore whether annual immunization doses will be required. Some amount of cross-reactivity has been published in earlier reports. There was this cross-reactivity report even with the dengue antibody, but assays have been kind of spruced up. They have been tweaked to become more specific, and therefore the amount of cross-reactivity these days are low. In regions with low COVID-19 prevalence, the risk of false positive results is higher. So this is true for any test and for any disease. If the prevalence is low, the positive predictive value is low, simply stated. Right now, India has a very high prevalence, and therefore the question of a low positive predictive value is negligible. So we thought we had this point of care test where we could go and keep these platforms in the clinician's office. If you had a consultation room and then expect the clinician to perform the test, to look at the test result, to issue a report, all this did not work out. So the actual technology which came out as point of care testing in real world became laboratory based tests. All these platforms are available in the lab. The greatest advantages of these platforms are A, that you have a very rapid turnaround time, which can be for an Abbott ID now, it is 15 minutes. For other platforms, it is less than an hour. And the other advantage that you have is there is no risk of contamination between samples because of cross-contamination or between the amplified products that happens in PCR. So, and the third, the most important for the laboratory person is the biohazard risk is minimal or negligible or not there. So, but the problem that why are we not using it? We are not using it simply because these are pretty expensive. Then there is this new technology that is already got an approval. In India, it's called as the CRISPR Tata MD check. It is something that is going to be a Tata product, but which has been designed by others. And this is something that will soon be rolled out. And there is this kind of a study that is planned to be undertaken to find out its feasibility. So the advantage is you don't need expensive equipment, and the results are available very soon. So then the only update that I thought I could include in this talk, in addition to the conventional test that we are doing, is the SARS-CoV-2 variants. So definitions of a variant are there in literature, and that is a SARS-CoV-2 variant, which means that it has a distinctive set of mutation or mutations, which confer a change either in the virus biology or its epidemiology. So how is it reflected? You have increased number of cases. So are we having a variant now in Maharashtra? You have increased disease transmissibility. So are we having a variant now in Maharashtra? Because I find plenty of households wherein the whole family is getting infected. So they can cause more. Are they causing more serious disease? Fortunately, and touch wood, not yet. They will have an impact on vaccine efficacy? Do they have an impact on therapeutics? Do they have an impact on available diagnostics? We saw that this UK variant had an impact on available diagnostics in those diagnostic assays which were detecting the S gene in GUL. Okay, so because the assays have multiple genes that are getting detected, so you are detecting the E gene, so you're not missing a case, but you definitely, it acted like a, what they called it as a surrogate marker for the UK variant. And when you find decrease in effectiveness of public health and social measures, all these things should flag the presence of a variant of concern. So what is it? So what's the big deal about the SARS-CoV-2 variants? All viruses mutate. We know this very well about HIV, and so does SARS-CoV-2. Fortunately for us, and probably not so fortunately for the virus, the SARS-CoV-2 has inherent RNA repair mechanisms. It accumulates mutations at a very slow rate compared to HIV. HIV has a mutation rate 4 times more than that of SARS-CoV-2. Currently, there are 4 internationally confirmed variants of concern. We know a lot about this UK variant. We stopped all those, or we started screening or testing all those returnees from UK. We know about the South African variant. We were slow to start testing, but we started testing all those returning from South Africa. We know about this variant from Brazil. And there is this cluster 5. Now there's something that is there to learn from this, and that is that this cluster 5 is now extinct. Why? Because all the minks which were infected, this happened in Denmark, were culled, or whatever is the word that is used, unfortunately, and they all died. And therefore there was no source left. With SARS-CoV-2, what is the problem that we are facing? Why did we not have such kind of a panic with, say, the swine flu, and why are we having so much of a panic with SARS-CoV-2? Because there is no real antiviral drug that is there at our disposal to give to everybody who we think is infected. I remember the times, even Dr. Supe was there at that time, when we had this swine flu pandemic. That was also a pandemic. It was initially we were in panic, but later on we settled. Why did we settle? We knew that it was spreading by droplets. We knew that it was also probably spreading by air. But why did we not panic so much? Because we had an oseltamivir at hand. Right now, we have nothing like that for all patients. So what could be the impact of these variants on diagnosis? They have the potential to reduce the accuracy of tests and give more false negatives. All variants have 8 to 10 mutations in S gene, and the S gene will not get detected with these assays. So the choice of test for an RT-PCR assay, and that is why the basic principle of any test choice should be that it detects more than one target gene. So what happened? We started converting an adversity to an opportunity. How? The S gene target failure became a surrogate marker for flagging of the UK variant. So the only detection method that is currently available for detecting these variants of concern is the genome sequencing, and we know that Maharashtra has geared up and is also since many months now for the genome sequencing, and we send our samples to NIB because we are in the West. And there are newer assays that have been already developed. There are 3 of them in the market that target these specific mutations, and therefore we can detect these mutants. So finally, what is the role of microbiological diagnosis? A, to identify cases. By what? Using RT-PCR for diagnosis, because it still remains the gold standard. B, it can be used to inform isolation decisions at diagnosis. So we know that if a patient tests positive for SARS-CoV-2 by RT-PCR, that person needs to be isolated from others to prevent spread of the disease. And at discharge, if there is a test-based strategy still existing, in KEM hospital, we still have a test-based strategy to kind of discharge the patient from a COVID ward to a non-COVID ward. So if those policies are still in existence, we will need a test-based strategy for this. And then finally, to prevent transmission, we have to identify contact, we have to screen the contacts, we have to test the contacts so that they could be asymptomatic carriers or they could be pre-symptomatic patients. So identify potential contacts so they can also be isolated. What these tests not to be used for? RT-PCR assays are not to be used as tests of cure or for prognosis. And RT-PCR assays should be repeated only when a patient develops a new set of symptoms and not otherwise. We have a lot of cases wherein the RT-PCR continues to be positive first they send every third day, then they start sending every week, and we have patients who have continued to test positive for almost 6 weeks, and we have a rare number of patients who continue to test positive for 3 months. So what are we going to do? What does it mean? Does it mean that the patient is infectious? Will he continue to remain in that ward? In that same 3 months, he can get reinfected with some other strain. So we need to take all these things into consideration, and let it be the test of choice for diagnosis. And this is what is our percentage positivity in all the samples that we've been testing since 20th March 2020, 19th March 2020. Actually, we saw it peaking in the month of May. Then it started slowly dropping. Then by August, it had dropped significantly, and it continued to drop till we thought we had reached comfortable levels. And we had just started giving signs of relief, okay? And now we are all back to that particular mode, though not as badly stranded as we were in March 2020, but definitely concerned and worried at the rising number of cases. We are back to where we were sometime in April 2020. Thank you very much for your patient hearing.
Thank you, ma'am. That was a really engaging session. And I think all those brilliant examples that you gave, residents like myself, and I'm sure all healthcare professionals, it solved a lot of doubts. So thank you so much for that, ma'am. And to our 500 plus viewers who are streaming this right now on YouTube, you are free to leave doubts, if any, in the chat box. Now we'll move on to our next session. The topic of the next session is the issues and the challenges in managing comorbid conditions in COVID-19 patients. We are privileged to have with us for this session Padma Shri Dr. Shashank Joshi sir, who is a member of the COVID pandemic task force. Sir is also the chair of International Diabetes Federation of the Southeast Asia region and the Dean of Indian College of Physicians. Sir, it is an honor having you here, and I please request you to please share your slides and give us an overview of the same.
Am I audible and visible?
Yes, sir. Yes, sir, you're audible.
Yeah. Thank you, Devashri, and thank you, Dr. Ravindra Devkar, for having this COVID session for capacity building. And after hearing Dr. Supe, Dr. Natarajan, I'm going to talk a little bit on COVID care and comorbidities. And the only thing we know about COVID is that it's predictably unpredictable. But we do have learned some lessons from ground zero on from Mumbai in COVID-19 and what should be the treatment protocol. So essentially, what I'm going to talk is, COVID in India. What's the evolving paradigm? A harmonized approach to treat patients because we are overwhelmed now with cases. Understand better about immunopathology and role of various biologics and steroids, because the only thing probably which has data on mortality today in COVID is probably steroids. And future treatments, of course, comorbidities, diabetes and hypertension I'll touch upon. So it's very crucial that, we need to understand the trinity between immunity, inflammation and intervention. And we know that there's a clear-cut cytokine signature, which is very crucial for clinicians' side on the severity and death. And this signature is basically an inflammatory and cytokine signature in COVID-19, which predicts deaths. Because fundamentally, we need to understand one thing, that we need to understand the immunology in COVID. And it's not just the antibodies, but it's the B and the T cells which mediate immunity in COVID-19. So a typical SARS-CoV-2, when it is inhaled and trapped, in our lungs, has two pathways. It might have a low virus titer or a high virus titer, and it can have two models. One is an adequate immune response, which is a timely innate adaptive response, which is a very rapid type 1 interferon response, which will have an efficient antiviral clearance by macrophages with activated Th1 cells and B cells producing a lot of neutralization. And that's what we want to happen. That's what we aim to do through vaccination if it is efficient. Unfortunately, in the vulnerable groups, in the comorbidity groups, whether it's hypertension, diabetes, age, and currently we are seeing a younger population with the new variant, you will have a faulty or inadequate immune response where there will be a delayed or limited type 1 interferon, endothelial cell death, epithelial endothelial leakage, and overactive or exhausted T cells and NK cells, and a lot of accumulated activated macrophage or a cytokine storm. And clearly, since ground zero from China, we have known the mortality indicators. And we know the predominant mortality was respiratory or myocardial. The current pandemic and the current strain with double and triple mutants probably will have more myocarditis and less of lung, but we'll see probably a mix and match of both. And we know that in the signatures of various biomarkers, some are well established and some are not well established. And we know that in hospitalized COVID patients, we have a clear correlate for risk stratification between severe COVID and non-severe COVID. So fundamentally, if you see the evidence base on various hazard ratios using various regression analysis on the variables for risk stratification, we clearly what stood out in the global world was age and the male gender. We know estrogen is protective and postmenopausal females lose their protection, and then various other biomarkers which I'll allude to. So clearly we know that what's happening today in the viral space is that there is a lot of pre-symptomatic patients which are transmitting a lot of virus, and that those are the spreaders and the super spreaders in the population. And this is something which Dr. Natarajan also alluded to, that 80% the disease is self-limiting. Whether you give them treatment, you don't give them treatment, they will recover and do extremely well. A good 15 to 20% would have severe disease. They will merit hospitalization, they will merit management, and we will need to understand which one of them might prove fatal. Usually it is 1 to 2%. So step 1 or stage 1 of the disease is asymptomatic. It's innate immune activation. It is viral engagement with the PAMs and the low type 1 interferon response. Typically, you will move into stage 2, which is non-severe or symptomatic. There will be adaptive immune activation, generation of antibodies and T cell response, and release of DAMs. And ultimately, what we are all trying to prevent are the 3 C's: the cytokine release syndrome, the coagulopathy, and the complement cascade. And that's the severe respiratory or myocardial inflammatory response. So typically, we know there is a very predictive time course model of adaptive immunity to any virus, and SARS-CoV-2 is no exception. Clearly, once the virus is entrapped into the system, we know the dendritic cells activate and uptake the viral antigens. And we have clear-cut induction of adaptive immunity through our immune system, where the T helper cells will make cytokines, the T regulatory cells will regulate inflammation, the cytotoxic T cells will kill the infected cells, and the T follicular cells will induce antibodies both from B cells, plasma cells, and of course, and eventually we'll have memory T cells and B cells both, which will be crucial in times to come. So obviously, induction of SARS-CoV-2 specific T memory cell and B cells, as opposed to circulating antibodies, which we measure, are the most crucial to offer long-term protection. And that's going to be the key as the pandemic evolves, because remember, we have 3 eras now. One was the pre-COVID era, now is the during COVID era, and then there'll be a post-COVID era. Crucial to immunology is the T follicular helper cells. They indicate maturation of the humoral response and establishment of a pool-specific memory B cells, and they respond very rapidly when there is a probable re-exposure or reinfection. And the specific CD4 T cells for eliciting this potent B cell response result in the antibody affinity maturation, and spike-specific T cells, which correlate very well with the neutralizing IgG titers and the IgA titers, whether it is the lungs, the gut, and other spaces. So it is very, very crucial that our bodies develop some robust immune responses, whether it is spike-specific neutralizing antibodies, memory B cells, or circulating T follicular helper cells, which are found from patients who have recovered from COVID-19 infection. From ground zero in China, what came out initially were 5 parameters or 6 parameters, which were crucial. And from the CBC, it was the neutrophil to lymphocyte ratio. But for me, beyond that was a simple RDW. If your red cell width is more than 14.5, you are reasonably certain that person will get severe COVID. And if the neutrophil to lymphocyte ratio is abnormal, also it is reasonably certain that you will get severe COVID. The D dimer, the CRP, the IL-6, LDH, ferritin are useful markers, but I feel they are reasonably expensive. And if you have a good complete blood count and CRP, it's good enough to predict severe disease. These were the various survivor, non-survivor biomarker assays. And what do we know today? What is put out here in the green is the one which has evidence beyond reasonable doubt. What is put out in the yellow is under investigation. So the simplest biomarkers we have are from the complete blood count. So leukocytosis, neutrophilocitosis, lymphopenia, and thrombocytopenia are normal in COVID infection. NK cell count is being looked at now. The simple transaminitis, a little bilirubin, BUN nitrogen, create, LDH being elevated is again something which is very classical, documented in COVID. So after 1 year, we know that the evidence based on this is robust. Myoglobulin, CKMB, cardiac troponin 1, CK are under evaluation, and a low albumin is also being investigated. D-dimer is something which we all know. It has its own challenges. I discuss when we look at treatment options, and fibrinogen and PT-INR are being looked at if they are elevated. The inflammatory biomarkers are the ones which have been discussed the most. ESR is under investigation. CRP, probably with the CBC, is the best marker we have. Ferritin, PCT are useful. IL-2 is investigational. IL-6 again has some green on it, but I don't recommend it to be given routinely. Post-COVID, often you see values of thousands after giving even after giving a tocilizumab. So don't get psyched on it. IL-8, IL-10, TNF-alpha investigational. Homocysteine is emerging. NLR, MLR are all there. So obviously all of them have associations with severe outcomes. Clearly we know what are we trying to predict. As clinicians, what we are trying to predict is who will undergo through an inflammatory and a thrombotic process. Because we know that there are two pathways the SARS-CoV-2 activates, is one on the right and one on the left. On the right is the cytokine storm with pro-inflammatory cytokines, shutdown of fibrinolysis, and impairment of natural anticoagulant pathways. And on the left is activation of D-dimer, FDP, APT, TPT, and platelets. And obviously, when there is a thrombin generation, coagulation activation, and the COVID clots, as they call it, it's those clots and the fibrin clots with the platelets which kill apart from the inflammatory response. So that's something which we recognize very well, and we have good data to suggest that. So WHO came out with COVID coagulopathy as a term, and we all know that if you have somebody with a high respiratory rate above 30, a saturation less than 93, a PA to FiO2 ratio less than 300, with more than 50% of radiological evidence over 24 to 48 hours, then it's obviously a severe COVID case. And clearly you need to start somebody on anticoagulant therapy, because you are going to get a mix of cytokine storm. They will need oxygenation. They will need hospitalization. They will need a prone position, because that's something which we recognize very well. High flow nasal oxygen and probably steroids. So obviously to predict severe disease, we need to look at immune dysfunction, radiological parameters, viral load. And viral load has been very controversial, as Dr. Natarajan very clearly said, that we can use better predicted markers, a red cell diameter or a simple red cell RDW or NLR or a CRP is much better as a parameter. And it's all about timing. So you have different scores like the COVID severity risk index to predict respiratory illnesses, H score for macrophage activation syndrome. And the most simplistic way to know somebody is mild, moderate, or severe, because that's very important to classify, is look at the saturation after 6-minute walk test. If it is more than 94%, we are good. If the drop is less than 3%, we are good. Respiratory rate less than 24, no pneumonia, CT chest being less than 25%. If you get mild GGOs, don't get panicky. Grade 1 GGOs, don't put them into hospital. Don't waste a hospital space for it. Just manage them symptomatically and wait if they desaturate, because the desaturation is the first marker. If they're moderate, of course, you know it is 25 to 75% involvement. Severe is more than 75% involvement. And then, of course, we have the simple parameters like RDW, NLR, CRP, ferritin, D-dimer, LDH, IL-6, and LFT. So clearly, when we look at treatment, the first active phase in the first 8 to 10 days is the viral response, where we have constitutional symptoms, fever, dry cough, lymphopenia. But it is the time when the stage 2A pulmonary phase sets in. That's probably the time you may need hospitalization, you may need oxygenation, and you might have shortness of breath, you might have hypoxia, you might have a PA to FiO2 ratio less than 300, abnormal chest imaging, transaminitis, low normal procalcitonin. There might be inside the hospital a role for a remdesivir, which is improving recovery, but it will not change mortality. And there might be a role for dexamethasone and oxygen. So clearly what has been seen here is these are the 3 agents which will work. And obviously it is very, very critical to understand the pattern and the course of the disease. For example, some people will rapidly deteriorate, have severe hypoxemia, respiratory distress, will need intubation and mechanical ventilation. Some people might have indolent course, where there will be moderate hypoxemia and moderate workup breathing, and they will also come out. Some people will have an initial indolent course. That means they're absolutely asymptomatic or mildly symptomatic for the 5 to 7 days, and then acute deterioration with hyperinflammation after 5 to 7 days. So these are three patterns in COVID which you need to recognize. First one, of course, is the rapid deterioration that happens in overall, if you triage patients, less than 5% cases. Second one is the indolent, which is improving and usually does well and can be managed sometimes at hospital or home itself. And the third one is the most tricky one, which we call as happy hypoxia, where people are having an indolent initial course followed by an acute deterioration, and that's where most deaths have occurred. So sometimes we need to intervene. And sometimes we need to intervene with oxygen and prevent that host inflammatory response with some monoclonal antibodies like tocilizumab, itolizumab, if steroids are resistant. So that's something which we need to recognize. And therefore, as the therapy evolved in COVID, initially people gave favipiravir, they gave hydroxychloroquine, nothing of that worked. They gave remdesivir, prednisolone, they had this itolizumab, tocilizumab, dexamethasone, ventilator, and we all know that the landscape kept changing. Different agencies had different protocols, like this is the Government of India protocol, this is the Bangalore protocol from Karnataka, this is the Government of India protocol. Then, but what was the key? The key was recognition of the cytokine release syndrome. So what is this cytokine release syndrome? Cytokine release syndrome is normally every viral infection we get, whether it is a common cold, flu, influenza, or COVID-19, they have a normal cytokine response to viral infections. But what happens with SARS-CoV-2 is we get a dysregulated immune response. It's an amplified response. So what is illustrated in this diagram, which Levy et al. Put out from New York very well, is that there is a hyper amplification of the pro-inflammatory cytokine response. What happens, you can see here in the illustration, is more T cells are recruited and they are hyperinflamed. So what SARS-CoV-2 does is it infects and destroys T lymphocytes, and that is why the T cells are eaten up. There is a lymphopenia, there is overwhelming viral load, and it magnifies the inflammatory response, causing lymphocyte exhaustion. And there are three stages of the cytokine response syndrome, which we need to understand very well. Stage 1, stage 2, and stage 3, and then need a clinical correlate. Stage 1 is the initiation stage, which is from 0 to 4 days. In this stage, typically you get early induction of chemokines and viral sepsis. Here the ferritin levels start going up and lymphopenia is observed, and infection-induced chemokines begin to recruit the innate and adaptive immune cells to the lung lesions. So basically they know that there is a problem, and obviously the innate and adaptive immune cells are going to the lung lesions. Stage 2 is the time which is the amplification phase, where there is a large production of inflammatory mediators and massive recruitment of inflammatory cells, including pathogenic T cells, to amplify the immunopathological process. And the stage 3, which occurs, and sometimes we can succumb because of that, is continuous increases in inflammatory mediators with widespread organ damages. So obviously, interferon system deficiencies can exacerbate severe pandemic virus infection. This was recently published just a couple of days back in the Trends of Microbiology. And we have two types of interferon response, type 1 and type 3 interferon response. In fact, there are global trials which are undergoing now, or phase 2 trials on interferon therapy in moderate COVID disease. And of course, that is how interferon is looking to be working out. You can see here a typical IFT M3 mediated imprinting, blocking of the viral fusion, and infectivity coming down very classically. And you can see here typically what happens, that when you have a robust interferon response, there is antiviral activity and the virus replication is stopped. Unfortunately, if we are interferon penic, or if we don't have adequate interferons in our system made by our body, there is uncontrolled virus replication, and that's typically what's happening. So SARS-CoV-2 fundamentally engulfs or infects macrophages. These macrophages present the SARS-CoV-2 antigens to the T cells. These T cells activate and differentiate and make cytokines with different T cell subsets, including Th1 and Th17, and these release a lot of cytokines. And what steroids do is fundamentally work on some of these subsets, and some of these subsets steroids may be resistant to. And fundamentally also, we remember that when you have a lot of these mediators made and there is viral persistence, then it has a negative effect on the NK cell, and the CD8 cell gets activated. And once the CD8 T cells get activated, they clear out the SARS-CoV-2 completely. And that's what is happening in our body: activation, exhaustion, and lymphopenia. And that's how the depletion and exhaustion of lymphocyte occurs. Neutrophils go up, cytokine storm sets in, and antibody-mediated enhancement occurs. So typically, you will either get multi-organ failure or you will get T and NK cell exhaustion, and you can later on, because of this immune activation, get uncontrolled secondary infections, and many of our patients in the hospital will lose because of secondary infection later. Obviously, we know CD6 is a co-stimulatory receptor in expressing T cells, and some of these Make in India compounds have been humanized monoclonal antibodies to that, and some of them have worked very well in the cytokine response syndrome. And these are something which we know that there are 3 types of these immune blockers. So if steroids don't work, then either we use an anti-CD6 monoclonal antibody like itolizumab, which will work on the ALCAM T cell activation, or we'll use an anti-IL-6 monoclonal antibody like tocilizumab, and which will probably may not have, it will only block the IL-6, or we can use an anti-IL-1 receptor antagonist, not available very easily in India, but available in Europe and USA, called anakinra, which is an IL-1 blocker. So either of them we can use. So obviously there are 2 types of blockers we have. One is a cytokine receptor blocker, which is tocilizumab, and one is a cytokine formation blocker. So if you have a patient on the ventilator already in the hospital, probably tocilizumab may be something which will be preferred. If you have somebody just rapidly not responding to steroids on oxygen, probably itolizumab is an early blocker. So one is a cytokine formation blocker, one is a cytokine receptor blocker, but this is a very muzzled pathway. You can see here, so many investigational agents across the world are undergoing phase 2, phase 3 trials. Everything in COVID is emergency use authorization. There is not a single drug which is approved for clinical use, except maybe the US, remdesivir and steroids. So remember that if you want to know who will get lung injury, and can we have a signature for lung injury, we really don't know. For example, we knew that for H1N1. In H1N1, we knew who will get cytokine signaling, the MAP signaling, the FTL1 signaling, and we know that typically H1N1 lung injury was like a M1-like phenotype. But now we understand lung injury of COVID, SARS-CoV-2 better. We know it's an M2-like phenotype. It has a coagulopathy pathway. It has a lot of transition from epithelial to mesangial transition. There's a lot of extracellular matrix organization and MET signaling, and therefore it is very different from H1N1, which is seen. And therefore, targeting these viral cycles, we still are searching those elusive agents. We know lopinavir, ritonavir was tried, it failed. We are trying those nucleotide analogs like remdesivir, which probably work only for recovery but not for mortality. And there is a search for these polyprotein chemostat,
Sachin sir.
clearly it has some data to show that it can. Slides got lost.
Yes, sir. There was some technical issue. Slides have been misplaced.
Am I back?
Yes, sir.
Yeah, I think there must be some internet failure. Nowadays, we have to get used to all this internet disruption. Where did I get disrupted?
Before this.
Okay, let me just see whether.
Various cytokines.
So let us look at remdesivir. I think that's where I was talking on. Remdesivir is still having some role in. Am I audible and visible now?
Yes, sir. Yes. Yes, sir.
So remdesivir is still useful for hospitalized patients where there is a clinical or radiological evidence of pneumonia with a respiratory rate more than 24, if there is hypoxia on board, and it is best seen in the first 7 days. And you give a loading dose of 200 mg IV in day 1, and then of course you give 4 more doses after that. Don't give it for 10 days and don't give it after 9 days. It really doesn't have data to support it. Can you do favipiravir remdesivir switching combination? We don't know at all. This is all very experimental. So I don't really recommend that at all because there are too many unknowns there. And then obviously we have new drugs? We have a lot of new drugs coming up. But we are actually in a different phase altogether. This COVID is going to continue till 2023, 2024. It will have peaks and valleys. It will have slow burns, and we don't know when it will stop. But the comorbidities of COVID are huge. You get cardiorespiratory complications. For example, you get clearly a sinus inappropriate tachycardia. You clearly get a myocarditis, which will be seen. You clearly get cardiac disease, which is seen, including myocardial infarction. On the pulmonary side, we get a tsunami of lung fibrosis, which is coming up very fast. We have COVID-induced diabetes, because of steroids, diabetes complications go up. And beyond diabetes, we also get hypocortisolism and thyroiditis. We get a lot of neuropsychiatric complications, neuromuscular syndrome, pains, femoral necrosis, and psychiatric complications I wouldn't allude to. I'm sure after me, Madam Parker will allude to all those post-traumatic stress disorder, depression, somatoform disorder, chronic fatigue syndrome. But comorbidities, which are biological, not psychiatric, like diabetic ketoacidosis, can be the first manifestation of COVID. In fact, my first encounter with COVID last year in March was a 92-year-old gentleman who had mild diabetes. First time came to a Lilavati casualty with the sugars of almost 500 and was admitted in the hospital. And later on, when we did a COVID test through the diabetic ketoacidosis hyperosmolar state, we found that he had COVID. Hypertension with diabetes, coronary artery disease, chronic kidney disease, chronic lung disease, COPD, obesity, all these are comorbidities. We know that in diabetes, if you are doing home isolation, most mild cases can be managed on oral tablets alone. But if there's moderate to severe COVID, you probably need insulin. If there is steroid use, you need insulin. And usually we need to stop drugs like SGLT2 inhibitors, which can cause dehydration. And insulin so often is needed by diabetics with COVID for 3 months. Fibrosis has a big problem with COVID. And we know that people are crippled with fibrosis. If you give antiviral therapy, one of the benefits of antiviral therapy is that later on you may not need to give lung fibrosis therapy. Otherwise, we'll end up with lung fibrosis treatment. That's a separate treatment and management. So what do we know about COVID today? Well, in mild COVID, probably nothing works. Favipiravir maybe in the first 24, 48 or 72 hours. Hydroxychloroquine, azithromycin more or less out. Doxycycline, ivermectin, no trials to document that. So it's all about experimental therapy. C, D, and zinc, we don't know. Aspirin, statin, we don't know. So clearly you can see none of these therapies have documented data to support themselves. You can see here, but at best you can do better viral clearance with favipiravir. That's the only data which is available. In moderate COVID, does remdesivir work? Probably recovery by 1 day, but mortality data 0. Timing of steroid is most critical. Between day 8 to day 12, give methylprednisolone for 3 days, 40 milligram BID in Michigan protocol, or dexamethasone 6 milligrams. Oxygen works, prone position works, non-invasive ventilation works, high flow nasal oxygen works. Low molecular work, heparin clearly saves lives. Okay, monoclonal antibodies like IL-6 or the itolizumab may work in select cases. So clearly, anticoagulants, if there is severe COVID risk, respiratory rate is high, CRP is more than 100, saturation is low, D-dimer is high, probably start them on low molecular heparin, give them 40 milligrams or 60 milligrams 12 hourly or once a day, or if there is a renal compromise, give IV heparin, 500 units, and consider Novak for 45 days. If they are low risk of thromboembolism with moderate cases and D-dimer is low, you might have to give subcutaneous low molecular heparin prophylaxis. If it is between 0.5 or more, but less than 3 times the normal, you might need to give an intermediate dose and give Novavax for 2 weeks. And of course, if it is more than 3 times, you may need to give the low molecular heparin 12 hourly and later on Novavax for 45 days. But currently, there are very global recommendations which are there on the so-called ICU care, ward patients, outpatient, and post-discharge. And various societies have told that in ICU and critical care, you need to give standard dose. In ward patients, you need to give standard dose for thromboprophylaxis. In outpatients, most of them don't need it. And post-discharge, unless and until there is a high risk, it is not recommended. So thrombotic and thromboembolic risk of COVID has to be modified with the critical care. And I'm sure Dr. Rahul Pandit will discuss that. D-dimers are frequently elevated in patients with COVID and are prognostic. High levels clearly suggest that they might have a risk for thrombosis and inflammation. And current data does not support routine use of high D-dimer levels for isolation in guiding clinical decisions. Levels should be assessed within the overall clinical context. We need to also correlate a thromboembolic pulmonary disease in hypoxemia, which is disproportionate to the X-ray changes. And when there is sudden worsening of blood pressure, heart rate, or oxygen. All patients with COVID should be assessed for, and majority will receive thromboprophylaxis. Optimal regimen is unclear. Most of them get a LMW, and most of them will do very well. Oral non-agents are not recommended. So the most important thing in COVID therapy is, are we missing the optimal time window? Because if you intervene early, you might just about save lives and delay salvage therapy. That's the crucial thing. And I think the most important clinical test, if you do a CBC, CRP and a 6-minute walk test with oxygen saturation, you can pick up patients who are likely to deteriorate early and fast and quick and administer them steroids appropriately. So probably in severe COVID, the role for IL-6 or ETOL is emerging now. There's a clear role for non-invasive ventilations, some controversial role. Covalescent plasma early or late is totally out now. All data is there, and post-COVID care is important, whether it is heart or lungs, whether it's diabetes or endocrine, or whether it is fatigue, is very, very important. And we of course need to do pulse oximetry all the time. That's the most important thing. And dialysis has to continue, non-COVID care has to continue. I see Dr. Dere here, he has done a wonderful job with field hospitals and oxygen beds. They have saved lives and food and shelter. The only concern is, does management change with mutants? You have a single mutant, double mutant, triple mutant, immune escape, vaccine escape, fast transmitting virus with low virulence. Management strategy doesn't change. COVID of the old strain or new strain is almost the same. So management strategy doesn't change. Vigilance changes. Probably the current disease is low virulent and unlikely to progress to severe disease. That's all which matters. So remember, the only thing is we need to be responsible, but COVID is predictably unpredictable and we need to save lives. That is the bottom line. And comorbidity is something which we need to recognize early and treat them aggressively. I think that is a vulnerable group, and that's the only thing which I wanted to say. Thank you for the opportunity for allowing me to speak in this August gathering. Thank you.
Thank you so much, sir. It was a very informative as well as lucid session. And you have really walked us in great depth about not only the pathogenesis, but also the treatment in a very algorithmic and streamlined manner, which is very useful for all of us. And it has been a great learning experience. Thanks so much, sir. Let's move on to the next session for today. The topic for the next session is mental health issues, which are often ignored in healthcare professionals, especially in the face of this COVID pandemic. And we have none other than Dr. Shubhangi Parkar, madam. Madam is member COVID Task Force on Mental Health. She is the former Dean of St. GS Medical College and KEM Hospital, and former professor and head of Department of Psychiatry at St. GS Medical College and KEM Hospital. Madam is also the ex-chief of the Drug De-Addiction Center of Excellence at St. GS Medical College. She has several accolades to her merit as well as several publications, and it is a great pleasure to invite ma'am to this session today. Ma'am, you may please share your slides for the day.
Yes. Can you see now?
Yes,
Yes,
ma'am.
ma'am.
Yes.
Run slideshow.
Yeah.
Yeah.
It's a very important perspective we need to talk. Remember that whole health begins with mental health. Unless and until that is strong, the physical health probably will not go ahead with the fights. The profile of, remember that, of different problems in pandemic, it is not just a physical risk to healthcare workers, but mental one too. The unfamiliar worry of having to make life or death decisions for patients multiple times a day itself is a huge problem. COVID-19, there are many unknowns have further added to the stress. In the beginning, people probably were walking in the dark, trying to find out some ray of the hope and do their best. But however, as we started knowing this unknown COVID, the things still are problematic. There is a hopelessness in the situation due to desperate actions which medical professionals have to take, because families cannot be at a dying patient's bedside. Frequent exposure to patients suffering and dying is a very, very stressful. I mean, this is not something which is expected over the time. There is a feeling of powerlessness a sense of failure at not being able to save lives, and classic post-traumatic stress disorder symptoms. Remember that post-traumatic stress disorder is a huge because it keeps lingering on in spite of the best attempts of the person who suffers from it. People normally get a chance to seek help and restore themselves. Generally this happens, we are in crisis and we probably take some help, restore. But during this pandemic, healthcare professionals, they do not get this chance. They have to keep working because workload is such and it is a very toxic situation. Quarantine of health workers may result in prolonged separation from family and other support system, especially friends, and that gives a loneliness. Okay, healthcare workers feel conflicted between their sense of duty and their willingness to work during a pandemic. I mean, it happens to many people that I am in quarantine, my friends are working, let me go and work, and there is a huge guilt, there is a huge feeling of frustration, desperate feeling. Okay, trying to strike a balance between professional responsibility and altruism, and that's a part of our profession, is a very toxic, a very burdening experience. Personal fear and anxiety can result in further dissonance and moral distress, because you feel every time you are working, you are also at risk, and that probably keep troubling a person that am I doing this? Am I going to catch up COVID-19? Am I going to quarantine? What would happen? So these are some of these things. I think stress, there is a huge literature on the stress. When we are understanding pandemic stress, let us understand what is basic stress. It is the reaction of people to extreme pressures or other types of unexpected demands placed upon them. And in COVID pandemic, this is what has happened. There were unexpected demands. Remember that distressing effects of stress on health and mental health are too many. There are social, psychological, emotional, behavioral, and medical. And in COVID pandemic, all these pressures were pretty high. Okay, there is a sadness of mood, fear and nervousness. These are psychological, phobic anxiety of having contracted COVID, feeling helpless, worthless, and hopeless because there is lot unknown around. Have desperate ideations, feeling confused, absent-mindedness, restlessness because the brain is really bogged down. Okay, there is a bad temper, annoyance, irritability, feeling of victimization. I think all the teachers must have gone through. The most important perspective which we really need to look at is a behavioral one. There is insomnia, that is difficulty falling asleep or early awakening. Remember, people shouldn't take insomnia easily. This is the beginning, or this is the red signal of many mental health complication or neuropsychiatric complication. The other basic disturbance is appetite, increase or decrease food intake, which is also risky because during when you're fighting pandemic like COVID, you really need good nutrition. And substance use, indulging in alcohol, tobacco chewing, cigarette smoking, and this has happened. I mean, there were many students contacting about this. Medical complication because of that stress, which is very toxic, consistent and continuous. It is worsening of pre-existing medical illness like blood pressure, diabetes, cardiac diseases, because stress is much more killing than any of this. In presence of stress, all these probably get worsened. Vulnerability to develop new illness because of low immunity. There is a lot about stress and immunity. If the stress is managed well, there is a natural immunity is developed. So how do we control the stress of the healthcare personnel during the pandemic? It's a very important because it is a catch-22 situation. We want our people to work hard. At the same time, we really need to help them to combat or control the stress. The set of expected problems in a healthcare worker In the beginning, it happens there were non-availability of PPE. There was social stigma. I know the nurses who were going home and the people in the colony were so stigmatizing attitude towards them. No, they were not helpful. There was anxiety whether I will infect my family members. And this anxiety is a killing anxiety because you feel so much guilty. Increase in number of cases in the city, so you have to work more. And breaking bad news, how you tell the patient or the relatives, how do you handle that particular aspect, which is emotionally draining. So there are a lot of things change over the period of 1 year. Burnout or psychological distress is a very important. This has impact on personal health and feeling of wellness, patient safety, and quality of care and healthcare system cost. Because if people have the brain fatigue, remember that it affects your concentration, it affects your judgment, especially clinical judgment. And then if you feel toxic, maybe a lot of commitment to the medical care will get affected. And that's a reason why we really want our doctors to be healthy mentally and physically. There are supportive interventions where regular psychological care is urgently required to address these needs. In KM, we have this model where Department of Psychiatry is talking to the people who need it. Peer support system, very important, because you share the stress, you share the caretaking, you don't feel alone. Then professional psychotherapy teams, which we require, especially if there is a post-traumatic stress disorder, if there is a depression, if there is a phobia, panic, and there is professional psychotherapy required there. Provision of the support for emotional and psychological needs that require to be understood, because so many times you just get fatigued, get angry, feel victimized, and there you really need somebody to listen to, talk to, and probably, give some advice. Providing online psychological services, which is a very important perspective. This can be done, okay? And face-to-face psychological crisis intervention is required. Last year we have seen many RMOs, many students were getting into trouble. They were not able to talk to the family, were not able to tell family what are they going through, and there were family pressures that you come back, you stay with the family, so there was a lot of fear. There is an encouragement and motivation intervention. This is itself a topic we are just sensitizing. There may be yoga, meditation, and other relaxation techniques. Art of Living people have done lot of such exercises in Bangalore, even in KM with the nurses. Okay, providing therapists visit to care their psychological sufferings and frustrations, which is very important. Implementing effective measures to reduce the number of COVID-19 patients. Ultimately, this matters because in the community, in the country, in the city, if you start controlling the COVID-19 spread, perhaps the healthcare workers will be little more relaxed. They will be able to take care of themselves. They will have that much time, to evolve and, get comfortable with themselves. And one more important thing, listening and incorporating what they say, which matters because healthcare workers generally are not heard so much by policymakers, by administration. So we really need to listen to them, especially the lower level healthcare workers like nursing students, RMO doctors or medical students who are working, because they do have their blocking points, their concerns, which we really need to handle over the time. Then we have important perspective is regular psychological care. This is what we have seen, providing online support system. Power of teamwork matters a lot. Because if the people are in teams, they feel they are not alone to go through this toxic phase of their life. They feel they're a part of a team, therefore they are sharing the same troubles, same benefits, and their, sukh aur dukh ek saath share kar rahe hain. That is very important. Teamwork together helps. There should be rotation in duties. There is a decrease in individual workload, which is probably a very important perspective. Of course, most of the cities had a trouble managing this because workload was very high. And feeling of unity, that I'm a part of the group which is altruistically managing this pandemic. So there is increased confidence. People feel good about it. So then we have to look at the mechanism of distressing. Whatever you feel, I mean, however you are comfortable, think about relaxing, in whatever matter. Maybe it is playing buddhibal, maybe it is playing guitar, maybe it is listening to music. But about our relaxation, everybody has different relaxation styles. Maybe talking to friends or going and having a good lengthy sleep, whatever. Okay, diaphragmatic breathing help to think and concentration. This is a very important. The meditation and anulom vilom pranayams, all these help, because they help in improving concentration, feeling relaxed. This is very important. There are breathing apps available which can be used anywhere. Yoga and physical exercise around 30 minutes, if possible, we have to get. There is a spot jogging 15 minutes, because walking around in the city is little difficult, unsafe. But all those cardio fitness workouts, all those things can be done, or maybe musical dancing can be done. So these are some of the important things. Power to of teamwork is very important. You're a part of team. That's extremely important. Then okay, something is happening. Page down. Coping with the stress, do's: eat well, healthy food. Okay, sleep well, around 8 hours if possible, maybe whatever maximum possible hours. Sometimes because of the workload you may not get. Talk to friends, use humor, use music, use dancing, and this is all helps. This is eventually contribute in development of the power to fight. This is a very important. In the cookie of life, friends are the chocolate chips. So we have to understand that. Words are easy, like the wind. Faithful friends are hard to find. So just find, if nobody else in the world, having some friends, will definitely help. Okay. So these are some of the issues which we really need to understand. Looking at pandemic, गुलजार जी कहते थे, इतना क्यों सिखाए जा रही हो जिंदगी, हम कौन सी सदियां गुजारनी है यहाँ. I think we have to remember that all these difficult times will be there, but tough times don't last, tough people do. So we have to give that kind of mind power to our people, helping them to relax and helping them to become tough. This is very important. And let them, go ahead with their own, power. This is a very important. Believe in yourself. In tough times, everybody is in trouble. Maybe the people around are not able to, help us to build up that confidence. So if you believe in yourself, things are possible. There is a beautiful song, Kabhi to milegi, kahin to milegi, baharon ki manzil rahi. So we probably will wait for that morning, which will be there after a tough night, and we will be able to, look after ourselves, look after our beloved ones. So how the belief that things will change, tough times don't last, tough people do. When not on duty, what to do about the time? Set goals, motivate yourself. Basically you will feel lethargic, you will feel lonely, you will feel there is a loss of energy, but you have to push. do your thesis, review your literature, whatever you are supposed to do. Find questions on the research on the COVID-19 pandemic. Just start working on what you are supposed to do. Start novelty seeking and have constructive approach, because there is no empty space in this world. There is no empty time in this world. We have to fill that time, with all positive things wherever possible and do best what we can. While don't become an altruistic savior at the cost of martyrdom. Working for 2 consecutive long shifts, if possible, maybe ask your friends to help. Maybe the administrator should be able to help. Not taking a break is not a good idea. Not sleeping less is not a good idea. So whenever you get time, start taking breaks, start sleeping more. Don't indulge in smoking, alcohol, and excessive caffeine, because these things give just time relief for some time, but they can cause a damage at a longer time. Okay, don't be unrealistic and immoral. Don't bunk your duties because you will feel guilty. So we have to help, sustain people, our friends, everybody. So that's where very important. Resilience is very important. I am capable of bouncing back. That should be thought. We probably may have the lecture on resilience and how to build, but it is very important. It is our ability to bounce back from stressful or negative experiences. See the business people, the artists, they have seen the bottom of the troubles, but they have come out, again on the mountains simply because they knew how to bounce back. And we have to learn to bounce back. To make simpler, resilient people are skilled at accepting, yes, this is a difficult time. I have to go through this tough time. They learn from what transpired. We have to learn. The last 1 year should not go waste. We have learned what was it, how to go about it, and what are the best ways to deal with it. And then keep moving on. You can't wait, can't stop. You're moving on. Philosophy itself will give a lot of energy. Seek help, talk to your friends, seniors, especially in the field of psychiatric disorders like depression. I think the people generally are not able to cope up with the depression. This is a very important illness, common mental disorder. So where disturbed mood is there, increased anxiety is there, feeling helpless, worthless, irritability is there, anger is there, feeling of victimization. Okay, now this has to be dealt with, because if we don't deal with the depression, people forget to take care of themselves. They are less attentive towards self, they are less attentive to others, and there is no compliance to medical and psychiatric medication. So we have to help people, to take care of depression, anxiety, some of this problem, suicidal ideation. Yes, as soon as it comes, don't feel trouble, don't feel how can this come to? This can come to anybody, and this comes in a situation which is overwhelming. So we have to tell people that this is what I am feeling, and start taking treatment, start helping. Okay, coping practically is wisdom and maturity. Just getting carried away with the stress is not a good idea. We have to decide what helps us, whether healthy diet, eating ice cream, sleeping well, listening to music, all these things which we have to do, whatever we feel. Okay, do some sensible things during tough times. It works. Okay, it really works. Instead of thinking about trouble, why not think about solution? It works. So good friends, yoga, anulom vilom pranayam, guitar, being with animals. I personally feel being with animals really gives a lot of relief, because you share with the people who don't expect anything from you. Okay, don't worry, be happy. I think all is well. We have seen that particular feeling, telling yourself all is well, probably will take you 2-3 steps ahead with your energy. A positive attitude gives you power over your circumstances instead of allowing your circumstances to have power over you. So don't allow circumstances to control you. Always control those circumstances and your life. Okay, the life probably will keep going, and that's a maturity. That's really living the life. Thank you so very much. Okay, so I think all of us have to live the life comfortably and as much as in without getting overwhelming. Certain things will happen to us, and certain things probably we have to change. Thank you so much.
Thank you, madam. Ma'am, as usual, it was a very beautiful and a really inspiring message to all of us. And I think our 400 plus viewers on YouTube, especially most of them are residents, they have received really useful tips to combat stress in these difficult times. So on behalf of all of them, I thank you, ma'am. We'll move forward to our next session now. The topic of our next session is issues and challenges in critical care management. And shedding light on this very important topic is Dr. Rahul Pandit sir. Sir is a member of the Maharashtra COVID-19 task force, and he's the director of intensive care at the Fortis Hospital, Mulund, Mumbai. Sir is also vice president of Indian Society of Critical Care Medicine. Sir has numerous original publications to his merit, as well as special interests in varied fields ranging from brain trauma to organ donation. It is truly a privilege to have you here with us, sir, and we are very happy that you could take out time. So if you could please give your opinions on the same.
Hi, thank you very much for having me on this program. I was not sure actually whether I'm going to make it live or not, so I sent a recorded talk. But it looks like I can do a live talk now. It's been a pleasure to be here with all of you, and I can see my colleagues at the task force, Professor Joshi and Professor Supe here, and all of you, of course. So I'm going to start off with my talk. If you could allow me to just share the presentation, here it is.
Yeah. Thanks a lot.
No problem. So look, the most critical aspect of any critical care is the ventilation of a patient. I'm going to basically talk about how you ventilate these COVID-19 patients and why is it so important to actually ventilate them correctly. So, in the 2020, the biggest challenge for us has been COVID-19 patients coming to our ICUs who look extremely comfortable when they come to us, but are profoundly hypoxic. Hypoxia, with which we have been grappling. And this has been one of the reasons, the happy hypoxia has been one of the reasons for developing a ventilation hesitancy amongst our colleague in ICU. Now, you must have heard of vaccine hesitancy, but there is a big amount of ventilation and intubation hesitancy, which I see. And if I could just take a few minutes to sort of explain to you where and how the oxygenation cascade takes place. This is how basically you start breathing. You have atmospheric air, which has got a oxygen concentration of 21%, which then goes to the alveoli. From there, it goes into the arterial blood, which then converts to your your partial oxygen pressure in your arteries, in the arterial blood, which is around 100 millimeters of mercury. And by the time it tissues and mitochondria, it actually drops fairly below. And you see that it sort of drops almost up to 20 millimeters of mercury. So when you begin having an alveolar gas equation, you actually drop down significantly by the time you reach to the mitochondrial level. And vice versa, the CO2 starts rising up as it starts reaching up to your alveolar level. And this is your oxygen dissociation curve. And here we can see the happy hypoxia. What I meant was the flat part of your curve here, for those who are actually remembering the physiology which was taught in Guyton. This is from Guyton. You can see that the saturation just before it starts to become steep, and it is actually correlating with the PaO2 of 92 here and a saturation of PaO2 of 60 here and a saturation of around 92 here. So that's what it correlates, the point where it actually starts to drop down, and that's what is called as an point where it becomes a steep curve. And there are 3 or 4 points which we look on this curve. One is an arterial point where saturation is around close to 98%, the PO2 resemblance around 100 millimeters of mercury. Your mixed venous point where the saturation is 75, and look at the PO2 drops down to 40. So if I go back on the curve, you'll be having a saturation of 75, but the PO2 would be 40. And then The third is the P50, where it actually halves. Your PO2 drops down to 27 and the saturation is 50. So again, going back to that curve, if your saturation was 50, look at the point where you will be having your PO2, 27. So when these patients come to you, they have a saturation of 75 or 80 millimeters of mercury. They are profoundly hypoxic. And if you don't do something for them at that point, you're actually going to have a problem. So what are the goals of the mechanical ventilation? It's to correct hypoxemia. You need to have enough oxygen to provide to the tissues. So you need to maintain a saturation of around 85 to 90%. And any attempts to have a higher level of oxygen may in fact be detrimental as well. So keep an FiO2 in such a place that your saturation remains at 90 to 92% and titrate the PEEP along with the same thing to actually try and keep the saturation at that point. You have to modify your goals a little bit. What is the goal? The goal is to actually reduce the work of breathing by using controlled mechanical ventilation, helping that with sedation and paralysis, and give the rest to your respiratory muscles. You could see that once the hypoxia sets in, you actually have a large amount of respiratory efforts which you keep on going, and the patient actually gets tired. And you need to wonder whether you're going to let this patient breathe at a rate of 35 to 40 breaths per minute, or you're actually going to give that respiratory muscles a rest. Problem with the COVID-19 scenario currently is many people are not identifying this and allowing the patients to tire out, and then they intubate when the physiological reserves have dropped down to almost nothing. And at that point, it becomes an irreversible problem. So COVID-19 is a bit of a different pneumonia from a standard ARDS, because long ago, which was almost a year ago, the great man Luciani Gattino, who is sort of the guru of the respiratory mechanics, actually came out with this concept. He came out with the concept of having two phenotypes, the L phenotype and the H phenotype. Now, what was this L phenotype? So what was common in both the phenotypes was both the phenotypes had profound hypoxemia. But the L phenotype had a very low elastance, and hence it had a very low recruitability, which means that it had very, very good compliance. Okay. And then these patients basically were responding to very low amounts of PEEP. But this category of patients also had some amount of pulmonary microthrombosis seen, and hence the hypoxia may have been accentuated in these people. Whereas the H phenotype, where you have a high lung compliance, high recruitability, high right to left shunt, which is a classic ARDS, you actually see the L phenotype progressing to H phenotype in majority of patients if not treated well, or sometimes the patient may present to you in a H phenotype. I would just like to take a few seconds to explain to you on a CT scan. On a CT scan, the one on the top here, you see that a lot of the lung seems to be preserved, and you would wonder why this patient should be hypoxic. But look at the PF ratio. PaO2 upon FiO2 ratio is below 100. Below 100 is a profound hypoxemic patient. Whereas this lung, which looks so bad on a CT scan, the PF ratio here is only less than 10 by the means of your PF ratio calculation. But both patients are equally sick. So just looking at the X-ray, you cannot actually determine that this patient is going to be hypoxic or not, and this patient needs to have a ABG. That's another second learning, that a lot of the times ABGs are not done. Patients are kept on just oxygen saturation, and we actually fail to recognize the deterioration until the saturation stops dropping down. And when it drops down very, very rapidly. Of course, the concept of this has been challenged, but I think it still holds a lot of water if you apply it in the way Luciano talked about it. Now let's look at the Berlin definition. Now this is the definition which all of us in intensive care have adopted for ARDS, and this was published as a revised definition for ARDS in 2012. What does it say? You need to have a new onset within 1 week of respiratory deterioration. So there has to be a reason why basically the ARDS is developing, and that timing should be within 1 week of a known clinical insult. You should have a chest X-ray or a CT scan which would not be fully explained by pleural effusion or lung collapse or nodules. You should have an alternative diagnosis for the fluid present in the alveoli, which is not explained by cardiac failure or fluid overload. And then you come down to your PF ratio, PaO2 upon FiO2 ratio in the presence of PEEP of 5 or a CPAP of 5. Either it is below 300, then it is called as mild. If it is between 100 and 200, then it is called as moderate. And when it is below 100, it is called as severe. The previous two scans which I showed you, one had a PaO2 of 95, the other had a PaO2 of 84. Both of these patients actually fall into the very, very severe category of ARDS. And they almost have a mortality to the tune of 50 to 60% if not treated well. So oxygen, oxygen, oxygen. You need to basically supplement oxygen to these patients to keep a saturation of greater than 93%. However, do not aim for saturations above 96%. Oxygen saturation between 93 to 96 is what you need to keep. There's a reasonably strong recommendation from surviving sepsis guidelines as well as from most of the COVID guidelines that hyperoxia is not you want. What you want is a normoxia, and normoxia is something between 92 to 96% oxygen saturation, or a PaO2 between 60 millimeters of mercury to 100 millimeters of mercury. If they remain hypoxic, you can use modalities like high flow nasal cannula, where we actually do a lot of high flow nasal cannula nowadays. Now, another thing which has actually changed the critical care in COVID-19 is, with the Berlin definition, we actually had a paper published in 2014 in the New England Journal of Medicine called as PROSEVA trial. In the PROSEVA trial, they actually ventilated patients with ARDS, and then sedated and ventilated patients were made prone. We used the same analogy to start a concept called as awake proning. And this concept was discussed right in the month of March and April, even in Maharashtra and Mumbai, where we actually talked about this concept. Me and Professor Joshi were talking about this, and we said that this is the way forward. We need to keep these patients awake prone. And here you can see the one on the left here is actually on a high flow nasal cannula and is lying awake prone. And the other patient here is just on a nasal cannula, just on oxygen cannula, is lying awake prone. Now, what happens is when you prone, these patients actually have a very, very good oxygenation because of the displacement of the mediastinal organs on the anterior chest wall. Thereby, their FRC increases. Once their FRC increases, they start ventilating well and oxygenating well, and they actually seem to recover quite quickly. Of course, for those who don't recover, high flow nasal cannula, this is something which has been around for almost 15 to 20 years. I used it in Australia extensively. People around the world have been using it. But in India, it has just come across in the last 2 or 3 years. And of course, COVID has given a big momentum to high flow nasal cannula. What is the drawback of high flow nasal cannula? If you don't have a central oxygen tank, and if you're basically dependent on oxygen big jumbo cylinders, then because the flows can go between 40 to 60 liters per minute, and if a patient is requiring a FiO2 of near to 90 to 100%, then you will be emptying one jumbo cylinder every 2 to 3 hours, and you will be utilizing all the oxygen for the hospital for only one patient. So this is not something which is useful for a small nursing home, but certainly bigger hospitals who have got good oxygen backup, you can actually use that. What is the benefit of it? The benefit of it over a non-invasive ventilation is the patient compliance. It is just like a nasal prongs, but it delivers humidified air and oxygen at a very, very high flows, and it sort of creates a CPAP effect, decreases the dead space ventilation, and thereby helps in patients oxygenating well. This is my data, and you can see that the PF ratio actually increased in all our patients who were put on HFNC. So I'm not going to basically talk a lot about HFNC because the concept is basically to talk about ventilation. I want to bring in one more category of concept here, which has come up in the last 1 year quite spontaneously in terms of the injury which a person may be causing to himself. So when you have these patients who have got very high work of breathing, they may be having a large tidal volume which may be getting exchanged with each breath. And that is basically detrimental, because we know that the ARDS lung, if you keep on inflating and deflating the ARDS lung quite extensively, you may actually have a concept called as a PCILI, which is patient-induced self-lung injury. Okay, and PCILI is more likely seen in patients who have spontaneous breathing efforts and who have a severe PF ratio which is below 200 or 100, and you may actually worsen it. Hence, it is very important to support these patients via an endotracheal tube and assisted ventilation or non-invasive ventilation. And this is what basically non-invasive ventilation does in ARDS. You can see that you would only delays your intubation. It only delays your intubation. So if you have to actually use non-invasive ventilation ARDS, you should be at the bedside identifying the patient, whether the patient has actually responded to the ventilation or not. I'm going to move across to the high tidal volumes, which non-invasive ventilation causes, and thereby causes the ventilator-induced lung injury or a PCL again. For patients who have got very high work of breathing, sometimes if you just put them on a non-invasive ventilator like a BiPAP machine, even you put very, very low pressures, you would still see that they are generating tidal volumes which are far greater than 10 ml per kilo body weight. And we want to ventilate them or oxygenate them using 6 to 8 ml per kilo body weight, 6 preferably. And here you can see this was published way back in 2016, where it shows that the moment you start using high time or start using non-invasive ventilation, a lot of patients actually had a failure of NIV because they were using large tidal volumes and thereby causing more damage than any good to these patients. And again, as I said, only delaying the intubation, nothing else. Now, let's look at the algorithm. And this algorithm is endorsed by the Society of Critical Care Medicine of America. And what it talks about, you have a patient who has got COVID-19 with hypoxia. If there is an indication for endotracheal intubation, and that indication is met, and that indication essentially is that patient has had a trial of non-invasive positive pressure ventilation or is unable to protect the airway, then go ahead with an endotracheal intubation. Do it in a way where expert is available and the best person in the house ventilates this patient. Use your personal protective equipment well, minimize the staff in the room, and use a video laryngoscope if you can. If not, then use supplemental oxygen. If not maintaining on supplemental oxygen, consider high flow nasal cannula. And after that, keep an eye when you want to intubate these patients. A lot of the time, we are actually spending a lot of time on HFNC, or we are spending a lot of time on NIV and actually not going to the next step. And this is where the problem is. You need to move to the next step and intubate these patients. Now, this is a percentage of patients who were basically ventilated across the COVID-19 pandemics in various hospitals in the world. The first 3 or 4 are from New York. Then you have a UK hospital, Lombardy, which actually was the epicenter at one time. And you can see that they had around 1,200 to 3,000 odd ICU admissions. And you had a percentage of almost 80 to 90% of the patients who required invasive mechanical ventilation. And out of the total hospitalized patients, almost 20% of the patients required ventilation. So people are actually ventilating these patients quite well, whereas we have not been ventilating these patients that well in our country. This is another study which basically talks about the same thing. And you can see that the mortality is ranging from 24% to 90%, 30% to 84%. So very, very high mortality seen in this group of patients. And why does the mortality happen? They have a severe decompensation, and those patients seem to have a severity of chest findings which are very, very bad. They have a profound hypoxemia where the PaO2 is below 50 and the PF ratio is below 150. And that is when you need to actually intervene and act in a proactive way. If you leave them like that and then intubate when everything has basically failed, the mortality will be very, very high. So the management should be that you need to have a protective lung strategy, and you need to use protective lung strategy using a low tidal volume ventilation and apply a PEEP, which will be below the lower inflection point, which is a very technical thing which the intensivists do to actually determine what should be the better PEEP to actually use in a patient who has come in with ARDS. Now, why am I saying this? Why am I saying that you need to intubate? There have been trials talking about this. This is the ARDSNet network trial, which was actually looking at low tidal volume versus high tidal volume, 6 mils versus 12 mils of per kilo per body weight, with the plateau pressure kept less than 30 or less than 50. And they basically found out that patients who had a low tidal volume ventilation had a far better outcome than those who had a 12 mils per kilo body weight tidal volume. And this was stopped after 4th interim analysis because there was a significant difference in mortality between the two groups, favoring the low tidal volume group. And the main outcomes you can see that the moment you use low tidal volume, your actual mortality was 31% as opposed to 40%. And you basically were having more patients breathing without assistance. You had a number of ventilator days which were even better, and patients without organ failure was also better. What about PEEP? I think the PEEP low versus high PEEP table is essentially good. You don't need to actually make the PEEP too complex, because the network was stopped for futility because there was no difference in survival between the two groups. So you can use high or low PEEP. There is no problem with that. And this is how the algorithm now goes across, that at stage 1, you calculate the predictive body weight. You use a tidal volume of around 6 mils per kilo, reduce it down until you actually reach 6 mils per kilo. In the second stage, you try and keep your plateau pressure below 30, and then you monitor your ABG. And once you monitor your ABG, try and optimize the ABG to keep a pH of around 7.15 to 7.30. Sorry. So who should be intubated, whether it's COVID-19 ARDS or non-COVID-19 ARDS? Patients who have moderate to severe ARDS, they should be ventilated, they should be optimized, and they should probably be prone. And prone ventilation is for patients who remain to have a PF ratio below 150 despite best of their efforts. Why prone position? Basically, when you prone the patient, what you do is ventral becomes dorsal and dorsal becomes ventral, and you actually increase the FRC, as I said. Blood flow redistribution happens, there's a change in diaphragmatic motion, and the secretions removal is much better, and the patients actually have a very quick recovery. This is the trial which I was talking about, 230 odd patients in each group. The Kaplan-Meier curve separated quite early, and the prone ventilation group had a far better outcome as opposed to the patients who were nursed in supine position after ventilation. Neuromuscular blockade, similar story. Once you intubate these patients, keep them paralyzed for 48 hours using a cisatracurium or vecuronium, you actually have a much better outcome in these patients rather than the other patients. For mechanically ventilated patients, now we are not recommending any recruitment maneuvers, because the recruitment maneuver which is being used as a standard of care now is a prone ventilation. Always remember, just ventilation does not help. You need to do your basics, and the basics in intensive care is the fast hug BID, where F stands for feeding, analgesia, sedation, T for thromboprophylaxis, head is for prone position in these patients, which helps the patient. Otherwise, traditionally, the head position used to be 45 degrees up. Ulcer prophylaxis, good glycemic control, spontaneous breathing trial, bowel movements, indwelling catheters to be assessed, and if not required, to be removed. And D for neurological disability, which in ICU is usually because of confusion or ICU psychosis or agitation. One of the last modalities is ECMO, which is extracorporeal membrane oxygenator. It's a completely different ball game. I would like to tell you that ECMO is essentially to be considered in patients who are relatively young, less than 65 years of age, and who probably have less than 7 days of mechanical ventilation. If you are using it for patients who have been mechanically ventilated or who have been non-invasive ventilator weeks together and then think of ECMO, the outcome is extremely poor. It's not a very good outcome in these patients. So you need to basically have a patient who would respond to ECMO, and it does not become like a non-responder. Now this is my data. Just 2 or 3 slides more, Dr. Devdekar, and I would be done. So this is my data from patients who basically are in intensive care. I have got a fair number of patients who are on the ventilator, and obviously a large number of patients who are on HFNC as well. And you can see that our ICU mortality is less than 10%. Our ICU mortality is 9.2%, and our ventilator mortality is 24.3%. Whereas I showed you some of the data where the mortality was ranging from 30 to 80% or 90%, our mortality is extremely low. This is in the numbers. This is data is up to August or to September last year. Up to September last year, I had around 514 patients in total, of which 50 could not make it, of which 464 were discharged successfully at home. 133 were ventilated. 99 ventilated patients were discharged successfully at home. 34 lost their lives. And there were 365 patients on non-invasive ventilator, which included HFNC. Majority of them were on HFNC, of which 16 passed away. And those 16 who basically didn't make it were patients who had an end-stage disease even before they came in. So they had an end-stage COPD, and there was an elective decision not to ventilate these patients, but to allow them to actually improve and give them a trial to improve on non-invasive ventilation if we can. Lung transplant obviously is a different thing. But my message to people is, do not delay mechanical ventilation if it is required. Prone the patients early, follow the basic rules, use muscle relaxation and sedation, and you would actually have good outcomes in these patients. Thank you very much.
Thanks a lot, sir. You have really beautifully and in a very engaging and informative way told us when to ventilate, how to ventilate, and what modality is the best. It was a really useful session for all of us, and I thank you so much for the same.
Thank you.
This draws us towards the end of today's webinar. And I would like to call upon Dr. Ravindra Devkar sir, who has been instrumental and who is also the moderator of the webinar for today, to please give his closing remarks and administer the vote of thanks. Sir is the additional professor at Department of Forensic Medicine at St. G.S. Medical College and KEM Hospital. Please, sir.
Thank you, Devashri. So good afternoon all. Gratitude is the fairest blossom which springs from the soul. So respected dignitaries, faculty, speakers, and dear audience, it is my privilege to propose the vote of thanks. We are very thankful to our Honorable Pro-Chancellor, Mr. Amitji Deshmukh, Honorable Minister of Medical Education, for his esteemed guidance towards starting this capacity building workshop for healthcare professionals, which is need of our to boost the confidence of COVID warriors. Also, many thanks to our IS, Mr. Saurav Vijay, Honorable Principal Secretary, Medical Education and Drugs Department of Maharashtra, for his esteemed guidance and kind approval for this webinar series. We are thankful to our Honorable Acting VCMHS, Dr. Nitin Karmalkar sir, and thankful to Dr. K.D. Chavan sir, Registrar MHS, who is behind the idea of this webinar, and the main concept comes from his brain. We are thankful to our honorable faculty speakers, Padma Shri Dr. Lahane sir, Dr. Avinash Supe sir, Dr. Geeta Nataraj madam, Dr. Shashank Joshi sir, Dr. Shubhangi Parkar madam, and Dr. Rahul Pandit sir for their wonderful presentation and in-depth information related to concerned topics. So thank you. We are also thankful to my MHS support team, Dr. Pradeep Avade sir, Dr. Deepanjali Longte, Dr. Chitra madam, Mr. Prashant, and our IT expert, Mr. Sachin. And at last, I am very thankful to my co-coordinator for this webinar series, Dr. Devashri from KEM Hospital. Thanks a lot. We acknowledge all the efforts of people who work in absentia behind the scenes and in the smallest way possible, and also acknowledge to all audience. This webinar had a wide range of audience from healthcare professionals of all streams. I am sure that the views shared on this platform has benefited each of the participants in a way or the other, and I would once again like to express our gratitude towards the dignitaries for the same. I hope that at the end of this gathering, each of one of us walk away inspired with ideas and actions that will contribute towards the betterment of community health in this COVID-19 pandemic. We are organizing such series of webinars in coming months. So please be tuned with us. Thanks a lot.
Thank you, sir.
Yes.
Thank you, sir. Just before we leave, for the participants, all of our viewers who have watched today's webinar, in case of any queries or any further help, you may write to the given email ID. Also, all those who could not watch today's webinar live, it has been pre-recorded and will be shown on the MUHS website in 2 to 3 days. Thanks again to all the distinguished faculty as well as our viewers for this beautiful webinar that has been conducted today. And I hope all of you all stay happy and healthy. Thank you so much, everybody.
Thank you very much, Dr. Devkar sir, Dr. Devashri madam, for a very excellent organization of this workshop. Thank you very much.
Thanks.
Thank you. Thank you very much, dear esteemed faculty. And I look forward to many more sessions which will be useful for all our medical fraternity. This is a good response, and I hope we can improve upon it more and more as time goes on. Thank you. Thank you so much.
So meeting can be ended now.